Ravindra ji, I will start at sharp 6. हो गया है 6. Okay. So should I start?
Yes, ma'am, we can start.
Dr. Shagun, Dr. Kinjal?
Yes, I think we can start.
Okay. So dear colleagues and friends, on behalf of Organizing Committee of Indian GI Cancer Congress, Chapter 1, I am honored and delighted to welcome you all. In this conference, there are 8 organizing secretaries, and these all are from different states of India. Many people ask the reason, and the idea behind this was when we all will work together, there will be some uniqueness. And yes, it is there in this conference. In this conference, everyone is active participant. Active because during registration, you all must have answered 5 meticulously chosen practical questions. And these questions will be discussed further in this conference in the form of multidisciplinary tumor board, talks, discussion, and we also have tried to have an expert opinion at the end and also to have survey results. So with these words, I would like to invite Dr. Divya to further moderate the session. Over to you, Dr. Divya.
Thank you, Dr. Rashi. Good evening, everyone. At the onset, I, Dr. Divya Khosla, on the behalf of Organizing Committee, once again welcome you all to one of its kind virtual conference, which is Indian GI Cancer Congress Chapter 1. Today, we'll be discussing the various aspects of management of carcinoma stomach and various dilemmas associated with the management. As Dr. Rashi said, we also have some case presentations pertaining to real life case scenarios, which we all face in our day-to-day practice. And to our conference credit, we today have eminent national and international faculty of repute, which not only will throw light on the management issues, but share their experience in treating this malignancy that will definitely steer the discussions to a new level. And as Dr. Rashi said, we also did online survey while preparing for this virtual conference. And the results of this survey will be discussed during these 2 days. So without wasting any further time, let's start this academic program. And for the first session, I invite our respected chairpersons, Dr. Shyam Agarwal. Sir is Senior Consultant Medical Oncology, Sir Gangaram Hospital, New Delhi. Dr. Shyam is renowned medical oncologist having more than 3 decades of experience. We welcome you, sir. Dr. Manoj Gupta, sir is President-elect Roy, Professor and Head Department of Radiation Oncology and Dean AIMS Rishikesh. Dr. Manoj Gupta started radiobiology teaching course, which is running successfully over the years. Thank you so much, sir, for agreeing to be part of this conference. And I humbly invite Dr. Sanjukta Padi, who is Associate Professor, Department of Radiotherapy, Acharya Harihar Regional Cancer Center, Cuttack. Handed over to our esteemed chairpersons to begin the academic program.
Good evening, everyone. I am Dr. Shyam Agarwal. So I think, take the lead and get going with the first session. So I think the GI oncology team is doing a great work by initiating this program, which is focused on stomach and esophageal cancer. And today is the day for CS stomach. And I think initially beginning with a panel discussion or a multidisciplinary tumor board on CS stomach, which is going to be moderated by Dr. Kanu Charan Patro, and he is the head of the Department of Radiation Oncology, as you can see, at the Mahatma Gandhi Hospital in Visakhapatnam. So I think CS stomach is like all other malignancies, is evolving in terms of molecular evolution, PDL1 based therapies, neoadjuvant chemotherapy and targeted drugs and so many other things. So I think it's over to Dr. Patro to introduce his team and get going with the first, multidisciplinary tumor board discussion. Over to you, Professor Patro, please.
Sir, good evening all. I am Dr. Patro. I am going to have a moderating one session on cancer stomach with multidisciplinary tumor board. We have a single case to discuss, and we have a panel in our group, Dr. Ashutosh Mukherjee, Tata Memorial Hospital, Varanasi, Dr. Avinash Pandey, AIMS, Patna, Dr. Moses, Dr. Moses, Tata Memorial Center, Calcutta, and Dr. Subhadeep Chakrabarti from Surgical Oncologist from Calcutta, and Dr. Vikas Goswami from Medical Oncologist from Delhi. So we have eminent panelists. Let's discuss and things we will have some conclusion at the end of the meeting. So this is the case details. Neither 27 years female presented with complaints of fullness after meals, intermittent vomiting since last few days associated with significant weight loss, for which she was evaluated. So as a 3 complaints here: fullness after meals, intermittent vomiting, and significant weight loss. These 3 things are the most common findings as you've seen in the most of the cancer stomach patients. So let's see, and upper GI endoscopy done. In upper GI endoscopy reported a hard nodular growth in the antropyloric region with a gastric outlet obstruction. So that's why the patient having the intermittent vomiting and loss of appetite. And endoscopic biopsy done. In endoscopic biopsy, mild focal acute chronic gastritis, but no H. pylori is seen. Duodenal biopsy reported as a giardiasis, and gastric growth biopsy seen the focal atypical single cell infiltrate low volume favors poorly cohesive carcinoma, sumperimpinged with a candida infection. So my very small questions to Dr. Ashutosh. Sir, are you happy with the histology report, or do you want to review or rebiopsy?
I would, am I audible?
Yeah.
So, okay. I am not really very happy with this report, and I would suggest a rebiopsy with, if possible, slightly more amount of tissue, because I would like to not only get the histopath profile, I would also like to do a molecular profiling of this patient. And the main reason is, like, over the last 3 decades, we have had multiple classifications, starting from the anatomical, then going on to the histopath, then going on to the molecular levels. And there has been some initial reports as well as some initial data that the treatment lines as well as the response of the patient would depend on what is the clinical, the histopath and the molecular subtype of the tumor. For example, even if it is an intestinal type, within the intestinal type, is it a CIN type or is it an EMT type? So all these would have a bearing on the final response to therapy as well as deciding the line of therapy as well.
So definitely I agree with Dr. Ashutosh. We have to review the histopathology report, and if needed, we can go for the rebiopsy. And if you see the molecular profile, we don't. We have a very few literature, and we are all in the infant stage to diagnose the molecular profile and molecular targeting the molecular level. So definitely there are 4 categories they have divided: chromosomal instability, EBV virus, microsatellite instability, microsatellite instability, and genomic stable. But these are 4 categories, but lots of mutations and molecule. But I think Dr. Suman will come and present in the next talk. So I'm not going to detail, but one thing I want to tell, though only we targeted therapy like the HER2 receptor and things, at least we can do the biopsy for the HER2, at least we can preserve for the future planning. So these are the various targeted agents, though it is in the preliminary stage in molecular level, but I'm not going to detail. I think Dr. Suman will go and present in these settings. So patient is very pet friendly, and he asked the doctor that I want a direct PET CT to evaluate myself, but I don't think PET is required as a primary diagnosis. But if there is a thinking advanced or some suspicious notes, then definitely PET is the one of the good thing. So if patient there is a mild increase in uptake in antropyloric region, and there is a gastric outlet obstruction, but there is no much nodes. These are the PET finding. So patient underwent a exploratory laparotomy, radical distal gastrectomy, gastrojejunostomy, feeding jejunostomy. So this mostly these are the common procedures, gastrectomy procedures with all stomach cases, and these are the standard surgery. So after that after that, histopathology details, it is a poorly differentiated carcinoma, non-syncytial ring cell stage. Maximum dimension is 5 centimeter. Lymphovascular invasion is positive. PNI is positive, and one by regional nodes or metastatic deposits, and 1 in 5 out of 5 in hepatic node, whether known as a D2 level, and it is positive. And clinically staged as a T4A and 1. So these are the histological findings. So I have some doubt. I think I have missing something, some reports. So I have a questions to Dr. Subhadeep. Hello, sir. Can you comment on the surgery performed? Is it adequate, or we should go for any more things?
Sir, good evening to all of you. There are two components of the surgery, and in the report that I am saying, one is whether a distal gastrectomy was should have been performed, or whether we should have gone for total gastrectomy. That is the second question. But in the first question, in the pathology report that I have seen, there are few things that I want to know is what is the proximal margin, the tumor-free margin from the tumor to the cut end of the stomach. That is not mentioned. I feel. And another thing is the lymph node yield. To qualify for a D2 dissection, the minimum lymph node that has to be dissected is 15. I think 9 plus 4, that is 14 or 13 in the report.
Sir, how do you define margin actually? Meaning how much margin distal and proximal? Is there any circumferential dissection margin should be there also?
So basically from the tumor to the cut edge of the specimen, there is a proximal should be at least 5 to 6 centimeters.
Okay, and a distal margin, sir?
Distal margin of 1 centimeter margin is okay. Tumor free, that is including the 1 centimeter plus the, if you're using a staple, but the staple line should also be checked, because a single staple line gives you another 0.5 centimeter.
Okay. So if there is please go ahead.
So at times we see the staple lines are not taken into account while reporting. So they leave out the staple lines. So because actually the surgeon has already put a staple line, so there is a 0.5 centimeter additional. So that has to be commented upon also.
Sir, if it is slightly lesion is more proximal towards the G junction, how much margin you prefer?
See, if I'm not able to have a proximal 5 centimeter margin, then it's better to go for a total gastrectomy than to go for a gastrectomy. Although there are studies for distal versus total gastrectomy, though the one of the multivariate studies, there are no overall survival benefit, but there has been the post-op period benefit is there in the distal gastrectomy population when compared to the total gastrectomy. And another thing is that in those studies, in that if you go deeply into analysis, we see that in one study, in French study was there, where they said the 5-year survival was better in the distal gastrectomy specimen than the total. But in that case, when the subset analysis was done, they saw that the total gastrectomy population had bigger tumors. So inherently, the bigger tumors will have poor survival.
Sir, CRM actually circumferential resection margin, they are not defined. Also, you give importance to CRM also.
Yes, sir.
So, how much margin you prefer?
Sir, ideally 5 centimeters approximately, and distal 1 centimeter.
Okay. No, I am asking for a circumferential resection margin.
Sir, circumferential resection margin more of importance in colon than in case of stomach.
Okay. So definitely there are lots of studies you can find. More than 15 nodes is the standard of care, and more than 25 is not much. We should harvest more. At least 15 nodes should be dissected. So welcome, Dr. Moses. How will you decide adjuvant treatment? Whether you go for chemo alone or CTRT alone plus RT, or give some sandwich like chemo radiation and send like McDonald regimen?
Yeah, so the role of adjuvant chemotherapy, I think, is well established in this setting. But the question of whether radiotherapy needs to be given is where a lot of controversies exist. So I think that was initially created by the intergroup study, the McDonald study, which showed that post-op chemoradiation had some benefit. But later on, I think in patients who have had adequate D2 dissection in the ARTIST trial, they did not show any benefit. But there was also a subset of patients who were possibly node positive in that ARTIST trial who possibly showed some benefit. So we used to practice the sandwich chemo-RT of chemo and then CTRT and then further chemo. So a subsequent trial which looked at only the node positive patients with this kind of regimen again has failed to show any benefit. So a role of adjuvant chemoradiation in someone who has undergone adequate nodal dissection that would qualify as a D2 is not there. So I would say that in someone who has adequate dissection, just the adjuvant chemotherapy is the standard of care as of now.
Okay, so there are lots of studies. Post-operative chemoradiation is a SWOG trial. When there is a observation versus chemoradiation, there is a definite benefit. And if you see the other trials where there is a chemoradiation after surgery, and it shows benefit, and you can see the Dutch group trial, D1, D2 trial. There is no benefit in the D2 dissection, but there is a benefit in the D1 dissection. And there is a retrospective analysis which showed that if you give given chemotherapy before and post-operative chemotherapy, they showed that benefit of preoperative chemotherapy is a better outcomes in the survival and things. So if you come to the ARTIST study, when there is a they have given capecitabine cisplatin chemo versus chemo plus RT. There is no benefit, but if there is a node positive is there, there is a definite benefit is there when you use the chemoradiation.
Dr. Kanu, could I just ask one small point on this?
Yeah.
I am actually not a very big fan of the ARTIST study. Simple reason that if you look at the methodology, both ARTIST 1 and 2 have used APPA fields, which actually increase the morbidity and would affect the results. If you look at the ZOO trial from China, Nanjing University, where they have used modern radiotherapy across the board, not just in node positive, across the board, the results have been improved in adjuvant chemoradiation. So, I mean, let us not harp about ARTIST. Okay, I accept critic, but not ARTIST.
Okay, let's see what happens next slide. So if you see the you see the MAGIC trial again. If you see the MAGIC trial, preoperative chemotherapy, surgery followed by chemotherapy, again compared to surgical resection. So chemotherapy, perioperative chemotherapy having the benefit in the overall survival. But if you come to the critics trial, when the perioperative chemotherapy, surgery and post-operative chemotherapy, and again if you go the post-operative chemoradiotherapy, only this thing is changed, only the adjuvant treatment is changed. So there is no significant overall survival as found between the post-operative chemotherapy versus chemoradiotherapy. So if you see the preoperative chemotherapy MAGIC trial, French group, post-operative chemoradiotherapy, preoperative chemotherapy, if you see the MAGIC French group and German trial, so they have shown that preoperative chemotherapy is better in the in the overall survival. But if you post-operative chemo radiotherapy, if you see the critics trial, Dutch D1, D2 trial, intergroup trial, they shown that not so significant benefit. But if you see if you used the preoperative chemotherapy, you can omit the radiation, as there is a critics trial told that there is no survival benefit. So if you see the all groups in one table, what I concluded that no radiotherapy if used preoperative chemotherapy and use adjuvant chemotherapy. If indicated, use chemoradiotherapy in post-operative setting if no preoperative chemo, and plot is the standard. Any comments? Okay. So any comments?
Dr. Vikas will answer your next question. Dr.
Okay.
Kanu, you have 2 minutes.
Okay, I will end within 2 minutes. Dr. Vikas, please, which type of chemo you prefer and how many cycles and any role of targeted agent?
So in adjuvant setting, usually we give capecitabine or 5-FU based therapy. If it is adjuvant, we give K-pox, which is easy to give. We may give FOLFOX. The duration is usually 4 to 6 months. In perioperative setting, a FLOT, like you showed, is the drug of regime of choice. However, not all patients are fit for FLOT. In those cases, we go with 2 drugs, which is platinum plus 5-FU or taxanes plus platinums as the choice, depending upon the comorbidities of the patient. Role of targeted agents usually is reserved for metastatic settings, not in adjuvant settings.
Okay. Thank you, sir. The gastric group meta-analysis, they told that 5-FU based regimens are good. And if you see the if you see the newer trials like classic study where observation versus capecitabine and oxaliplatin group, mostly capecitabine and oxaliplatin group based, there is a good 5-FU survival benefit over the surgery alone group. But if you see the real true study, what is the premature data has published, they told they showed that in place of cisplatin you can use the oxaliplatin, and 5-FU you can, in place of 5-FU you can use the capecitabine. So these are 4-arm study, and they showed that 5-FU we can replace 5-FU, which is a very long regimen, infusion regimen, we can replace with the capecitabine, and you can use the oxaliplatin. So adjuvant, as Dr. Vikas told, oxaliplatin and 5-FU based regimen, the patient received 6 cycles of FOLFOX based adjuvant chemo. So if you see the one thing, if you see the ISMO algorithm, if there is a operable, you can go prefer the preoperative chemotherapy, surgery and postoperative chemotherapy. But if you want to direct go for surgery, there you can see this line, preferred pathway. Even operable regions, they are planning for the preoperative chemotherapy, surgery, postoperative, because you can get a more pathological response and good thing. And if you go on for surgery, give for adjuvant chemoradiotherapy or adjuvant chemotherapy, and inoperable and metastatic choice is yours. So even if in operable cancers, you go for preferred pathway, the preoperative chemotherapy followed by chemo. So Dr. Avinash, please, can you roll up a targeted agents in the adjuvant setting? As you anything we should use in the metastatic settings only? Dr. Avinash, I think he is not in the line.
You can hear me?
Yeah, we are.
Hi, can you hear me?
Able to hear, please.
Yeah. So in adjuvant setting, HER2 positive disease, role of trastuzumab is still exploratory. Trials are going on, so we don't know whether adding trastuzumab in adjuvant setting in HER2 positive disease over chemotherapy, it will add a meaningful survival benefit is yet still to be known in a adjuvant setting. But we have data for metastatic setting of TOGA trial in which it has shown benefit at least 1.5 months with in overall survival. So maybe time will tell whether in adjuvant setting adding HER2 based agent would help or not.
So as Dr. Avinash indicated, the TOGA trial, everybody knows this one, and there is a meta-analysis. You can see the there is a 5 randomized control trial. There is a 1 year, 2 year, and overall response has improved in advanced and gastric cancers. So there are various biomarkers they have mentioned, but all are, I think, it is in infantile stage. more studies and more
Dr.
data.
Kanu, I think we need to
And
wind
these
up
are the biomarkers what we can use. Anything you want to insist, Dr. Avinash? Okay.
Nothing. Even in metastatic setting, increasing dose of trastuzumab has not helped. Adding pertuzumab in gastric cancer above trastuzumab is also a negative study. We really have to see in adjuvant setting if it is added, will it really add into improvement in overall survival? Not only time will tell.
Okay. So in the follow-up case, Dr. Ashutosh.
Dr. Kanu, we have to wrap up now. I think you can take a couple of questions and you can finish now.
Okay, just one slide only. Yeah. Pattern of follow-up, any supplementation you need, Dr. Ashutosh?
Yeah, I would go ahead with calcium, vitamin B12 supplementations. Also check for fat malabsorption, and if there is steatorrhea, give fat supplement, lipid supplements, and if there is any, we have to monitor for basically rule out dumping syndrome also in these cases.
Okay, thank you.
Patients need extensive support, definitely.
So, patient after whole body PET CT, there is no disease because as I told, patient is PET friendly and there is no segment changes and patient, no uptake. And this is the PET CT. And thank you very much for attending the panel, and thank you for the invitation, the organizing committee.
Thank you, Dr. Patro. So good evening to all. I am Dr. Manoj Gupta. Now, so stage is set by Dr. Patro very nicely, and now we have a lecture by Dr. Suman Malik. We all know that it's not just the face value, but the biology of the tumor which ultimate matters, not in terms of outcome, but also how the tumor is going to respond to various treatment options. And to discuss that, I invite Dr. Suman Malik, who is radiation oncologist at Narayana Super Specialty Hospital, as you can see from the slide. So over to you, Dr. Suman Malik.
Thank you, sir. Good evening, everyone. And at this outset, I would like to thank the organizer for giving me this opportunity. And I'll discuss a few aspects about molecular classification of gastric cancer and its implications for radiation oncologists, if any. So as we all know that the gastric cancer is one of the leading causes of cancer-related death worldwide, and it's a multifactorial disease. It indeed a heterogeneous disease, and the standard treatment, as we had the discussion before, is the surgery along with preoperative chemo and adjuvant therapy in localized cases, and for advanced cases, palliative intent therapy along with the systemic therapy. And we see a lot of recurrence in gastric cancer. About 40 to 50% cases, they recur even in early stage in 5 years. Now the question is whether this gastric adenocarcinoma is a single disease. Probably not, because we know that intestinal type is not exactly like diffuse type. Anatomically, that is, these are different. Geographically also these are different, and for that reason there was a need to assess the molecular subtypes of gastric cancer. And this is the standard classification we used to follow. That's a Lawrence classification that usually we divides it in 3 groups: intestinal, diffuse, and indeterminate. Who came up with a more extensive classification in 2010, but this is of no use as far as clinical implication is concerned. So in 1992, Korea actually proposed this hypothesis of cascade of formation of intestinal type of gastric cancer from normal gastric mucosa to intestinal type mucosa through chronic atrophic gastritis, intestinal metaplasia, dysplasia, etc. And this transition actually been seen in molecular subtypes as well, and we have seen that each individual sector has characteristic genetic pattern. So we see usually more free radicals expression of TNF alpha, IL-6 in this chronic atrophic gastritis. We see TERT activation in intestinal metaplasia, MLH methylation in dysplasia, and when it is a frank intestinal type adenocarcinoma, it's usually with the lot of heterozygosity in TP53 APC BCL2, loss of P27 TGFBR1, and other that I'll discuss later on. And when we talk about diffuse type adenocarcinoma, usually it form from normal gastric mucosa through histone deacetylation in E-cadherin loss. So the Cancer Genome Atlas actually came up with a new classification system, and goal of this new classification was to develop a robust molecular classification of gastric cancer to identify the dysregulated pathways and to identify the drivers for distinct classes of gastric cancer, so that will help us in future directed therapy. And they characterize samples using 6 molecular platforms. One was array-based somatic copy number analysis, second was whole exome sequencing, third was array-based DNA methylation profiling, fourth messenger RNA sequencing, microRNA sequencing, and reverse phase protein array. And they postulated four distinct types. One was Epstein-Barr virus, second was microsatellite instability, third was genomically stable, and chromosomal instability. So let us discuss one by one. So in Epstein-Barr virus, usually it is seen about 8 to 10% of cases. It's more prevalent in male, and it is more frequently located in fundus and body, and it is usually associated with 80% times its PIK3CA mutation. Along with, we see PDL1, PDL2 mutation, and this group is associated with good prognosis. And the next one is microsatellite instability, which is around 20 to 22%, and more prevalent in female and at older age group. And usually in microsatellite instability, we see lot of mutations and lot of mutations in ERBB, P10, PIK3CA. And here, based on the microsatellite instability level, so we classify that as a MSI high and MSI low. So if you compare MSI high with MSI low, MSI high is associated with better prognosis compared to MSI low or MSI stable. The third group is genomically stable type, which is around 20%, and this is usually associated with diffuse histology and poor prognosis, and usually this is mostly avoid of any specified targeted pathway, and the target we see usually that the RHO-A mutation. Still we do not have a dedicated drug for RHO-A mutation, and if you look at the outcome of this group of patients, its outcome is very poor, and they are poorly responsive to chemotherapy. And most common category that we see, that is the CIN or chromosomal instability type. Around 50% of gastric cancer patients, they do have CIN type, and mostly they are of intestinal histology, with intermediate prognosis, and most common location is the proximal stomach, that is GE junction and proximal stomach, and these are also associated with lot of mutations. So if you look at the mutational rate, the highest mutational rate we see in MSI type. So let us have some discussion with this figure. So this is the intracellular gastric cancer pathway. So in intracellular gastric cancer pathway, we have actually identified lot of targets for gastric cancer cascades. So most common is the EGFR pathway, as Avinash discussed before. So we have EGFR targeted agents. For EGFR1, gefitinib, erlotinib has been tested. For EGFR for ERBB2 types, trastuzumab has been tested in, and it has shown overall survival benefit in case of advanced gastric carcinoma. So now it has become a standard of care now for advanced gastric cancer. And we have lapatinib for pan EGFR blockade, EGFR1 and 2 blockade. There is another area for targeting agent, that is the VGF pathway. VGF pathway. So VGF bevacizumab has been tried, and ramucirumab has also been tried. And usage of ramucirumab has shown there is overall survival benefit, and now it is used for VGFR2 positive tumor. So, and there are other targets as well, that hepatic growth factor, MET is associated with poor prognosis. So based on this risk stratification, that cancer genome atlas for gastric actually divided this TCGA score, raw score, as 1 minus EBB probability plus 1 minus MSI probability plus GS probability into 2 plus CIN probability. And that risk score is equal to T to the power TRS raw. And this generated TRS value ranging from 3.2 to 85.27. So they defined low risk stomach when the score is less than 20, intermediate risk when is 20 to 30, and if it is more than 30, it is high risk of recurrence. And based on this risk stratification, if you look at the relapse-free survival and overall survival, you can see the distinct difference between three risk groups. And now the thing is, what is the role of therapy in this kind of categorization? So we have seen as I said already, that EBB is associated with best prognosis, MSI and CIN associated with intermediate prognosis, and most worst prognosis with the genomically stable. And if you look at the response to chemotherapy in genomically stable group, there is no response to chemotherapy. So addition of chemotherapy probably doesn't help in genomically stable disease. And PIK3CA mutation, as I mentioned, it's more common in EBB group than MSI, and it's very less in genomically stable or chromosomal instability. Elevated PDL1 and PDL2 is also more common in EBV group, and this is one of the important target, though it is a indicator for poor prognosis, but it is one of the important target for third line chemotherapy in palliative setting. We have seen that in CIN there is high amplification of oncogene compared to other groups, and in genomically stable, as I mentioned, there is a ROA. So if there is a ROA blocker, then a ROA blocker, then we can consider for ROA blocker for genomically stable, but this is under evaluation. So in bird's eye view, if we take all this group, so histologically diffuse is more common in genomically stable. And if we look at the anatomic location in G junction or cardia, the more common is CIN. In fundus and body, we see EBV group, and CIN is more and less common in all on anatomical sites. And this is the Western data, and this is Asian data. If you look at the prognosis associated with each or 4 subtypes, both are similar. Best is EBV and worst is genomically stable. So this is the difference of past with the present. So we used to define gastric cancer as per the location of the disease, but now we try to define as per its molecular characteristics. And Dr. Kanu has already mentioned about the adjuvant trials, that intergroup trial where there was the role of radiotherapy was established, but it was largely criticized due to inappropriate surgery and lot of toxicity of radiotherapy. And artist 1 and 2 has already been discussed. if we look at the this trial more closely, so when we look at the outcome data based on the molecular subtypes, we will see in even in Magic trial, we have seen there was detrimental effect of chemotherapy in those patients who had MSI high. If you compare MSI high without chemotherapy compared to with chemotherapy, so in those patients who received chemotherapy did worse compared to who did not receive chemotherapy. And in this meta-analysis, it has also established the same aspect that there is no benefit of chemotherapy. This is in adjuvant setting in MMR deficient MSI high gastric cancer. Similarly, in classic trial, where surgery versus adjuvant chemo was seen, in those patients who had MSI high, there was hardly any difference in outcome, but where there was MSI was low, there was significant difference in survival in those patients who received adjuvant chemo. Critic study, so there is they have shown no advantage in addition of radiotherapy if there is D2 dissection. ARTIST2 has already been discussed, but one thing I want to mention in ARTIST2, because in ARTIST1 it was shown that probably node positive case where in intestinal type probably there is benefit of radiotherapy in subset analysis, but in ARTIST2 there was only 1/3 of patient was they had intestinal tumor. These are the ongoing recent trials on pre-op chemotherapy plus minus radiotherapy. One first is Top Gear, and it's on G junction 752 patients. Second is ESOPEC study checking FLOT versus cross regimen. Neo Aegis also looking at FLOT, ECF, and cross. And Critics 2, it's looking at cross versus DOC and DOC followed by chemoradiotherapy. And results of these trials are pending, and they are also coming up with the molecular classification as well. So on basis of molecular classification, what is the importance of adjuvant or radiotherapy as a whole? So probably we'll be able to answer in next few years. So as of now, adjuvant radiotherapy in gastric cancer, it improves OS if there is less than D1 resection. It improves survival when margin is positive. As per ARTIST1, as I mentioned, probably there is benefit in N+ intestinal type, but ARTIST2 could not validate the benefit of radiotherapy in N+ disease when there is D2 resection. ESMO guideline already Kanu has mentioned. So as per our NCG guideline, so only role of radiotherapy has been mentioned, that is D1 dissection or margin positive in adjuvant chemoradiotherapy, apart from the palliative setting radiotherapy. So to summarize, so we know that distinct gastric cancer subtypes and with striking genomic features would provide probably a roadmap for development of newer molecules and next level of therapy and next level of sequencing of therapy. And implication for prognosis or response to standard treatment is currently sketchy owing to lack of sufficient data. And present role of radiotherapy, as I mentioned, in gastric cancer, a positive margin less than D2 resection and palliative setting. Thank you very much.
So thank you, Dr. Malik. You completed your talk well within time. So thank you very much for this. Now I invite discussant for discussion on this topic. So I invite Dr. Arun Verma, Dr. Amol Ubel, and Dr. Vipul Natyal. So over to you all three.
Okay.
Dr. Vipul,
Thank you, Dr. Malik. You nicely summarized. I am Dr. Arun Verma. Good evening, everyone. And you covered almost all our topic. My take on these molecular classification is that though this is the evolving field, but it having a lot of inherent bias, and because what is the we don't know the complete clinical significance of these molecular classification in the clinics, and it is associated with high cost and complex techniques and limited utility. And there may be heterogeneity, as you discussed about the Asians and the MD Anderson data. There is heterogeneity, especially in the CIN group. So we don't know what is going on the Indian data. What are the percentage of the Indian molecular classification? So if anyone is aware about the Indian data, that may share. As far as the adjuvant radiation therapy is concerned, presently there is no even phase 1, phase 2 study based on the molecular classification who exploring role of radiation therapy based on these molecular classification. Yeah, but many trials are going. We have to wait for the molecular classification in the field of radiation oncology. That is my thank you.
Good evening, everyone. There is another classification, Asian Research Group of classification, in which they have divided this MSI, and another is microsatellite stable, in which P53 mutated wild type, and as well as the third one is the EMT type. So EMT type is the worst prognosis, having diffuse histology. So the adjuvant chemoradiation should be given only in those patients where the chances of local recurrence will be high, like if the margin is positive, or the intestinal type where the local recurrences are more compared to the diffuse histology. So I would be preferred to give on those patients where the local probability of local recurrence would be high, along with the chemo.
Okay. Good evening, everyone. Very nicely explained by Dr. Malik, all the factors. But very exciting to know a lot of new things we came across today. But how much role is there for radiation therapy because of these factors? How many are we going to increase any dose, or these things will be coming in next few years? As of now, it is much kind of theoretical knowledge. And practically how much we are going to use for radiation therapy as of now, I'm not very sure. Many things are coming forward for chemotherapy right now for molecular level and all, but in future we'll be able to know what we are going to do with radiation therapy in all these factors.
And most of the time we are getting the patients who are having only less than D2 resection.
Yeah,
so,
yeah. So in that patients, radiation should be given
option after the surgery.
Yeah, yeah, right.
Can I make a comment here? You see, it's very interesting to know that we are moving from histopathology to the molecular kind of thing in every sites. Now, whether what will be the role of radiation oncologist once these molecular patterns are established for various type of cancer? What I feel as a radiation oncologist, and there are some data on other sites. For example, in head and neck cancer, if you look at the DANCA trials, where they have used accelerated radiotherapy, I mean 6 fractions per week, and reduce the overall treatment time, they observe, of course, that is a retrospective data analysis later on, but they observe that when you do a modest acceleration in radiation treatment, it only benefits P53 mutated cancer, not all the cancer in the area. So these, and there are other data also, which are based on molecular marker, like if you have EGFR positive cancer, which are more than median, then again, when you give, accelerated radiotherapy, then they benefit more, right? So what I'm trying to tell that, this is just the very, very beginning. And, radiation oncologists are looking at the individualized fractionation based on molecular marker. So same thing maybe in future, maybe in future, not now, but maybe in future, we can also be in a position to individualize our fractionation scheme based on various molecular markers. So that is my comment. Thank you.
Yes, sir. I completely agree with you. So it will take a lot of years, I think, maybe not less than 5 years from now to see these things, but let's see.
Thank you.
Thank you, everyone.
Thank you so much. Thank you. Yeah.
Rashi, hello. Am I audible?
Yeah, you are audible, ma'am.
Thank you.
Welcome.
Good evening, friends. Thanks, organizers. At this outset, I am inviting Dr. Rina Engineer, Professor, Department of Radiation Oncology, Tata Memorial Hospital. She is pioneered in GI and GU cancers. She needs no introduction. With this, I am Dr. Rina Engineer, please. She will be talking on current thinking in integrating adjuvant radiation in carcinoma stomach. Dr. Rina, please.
Yeah, hello everyone. I'm just trying to share my screen. Yeah, just. Yeah, good evening, everyone. It's always a pleasure to speak among our fellow radiation oncologists and so knowledgeable people. And I would say they are the complete oncologists, you know, and they understand the disease as a whole. And so I would be speaking, and I was listening to Suman's talk and Kanu. They have already shared many of the slides which I was going to share, but it's okay. We can go through it again. And like as we all know, gastric cancer is purely, you know, R0 resection is the only curative treatment for it. And in spite of all these advances in node positive and locally advanced gastric cancer, 5-year overall survival is around 25 to 30%. Therefore, we are talking about additional treatments which need to be given as a perioperative treatment, either in the form of chemoradiation or chemotherapy alone, to improve the survival outcomes. This McDonald's trial, I think all radiation oncologists, though they know the results at the tip of the fingers, and though this was the first trial which showed that there was advantage in giving chemoradiation in the adjuvant setting, where less than D2 dissection or only D1 or D0 resection was performed, and therefore there was definitely improvement in 10% improvement in overall survival, and this survival advantage continues up to date even in the 10-year analysis. And this made really, it was a landmark trial of those times. And though there were so many criticisms about the technique of radiotherapy and the toxicity and all, but it still remains, you know, and we do practice in our routine care that kind of treatment, but with advanced radiotherapy techniques. Now, about this MAGIC trial, I'm not going to discuss, which also was a landmark study which compared surgery alone versus perioperative chemoradiation, perioperative chemotherapy of ECF alone. So then the question came in our mind that is ECF superior to the 5FU, and what is its interaction with radiation? Is it more toxic when we give it with radiation? And what is the role of radiation in the era of D2 resection, where D2 resection has become the standard of care? And this trial was also a very nice trial, which we should all know, the CalGB trial, Alliance trial. It was published recently in 2017, where the radiation was given, adjuvant radiation was given in both arms, and the chemotherapy was 5FU leucovorin standard chemotherapy versus ECF chemotherapy. And we see majority of the patients in both arms, 66%, managed to complete the treatment without toxicity. And mind you, this trial was basically designed to overcome the criticisms of McDonald's trial, where the radiotherapy technique was inferior. And this radiotherapy technique was 3D CRT, but in a very controlled manner with proper QA and all. And we see that 55% patients had kind of more than 15 lymph nodes dissected, so more than half of the patients. And at the median follow-up of 6.5 years, there was no difference in overall survival or disease-free survival in either arms. So this trial concluded that ECF is not superior to standard 5FU and leucovorin after radiotherapy. And when we have to give radiotherapy in the adjuvant setting, setting, it is 5-FU leucovorin remains the standard of care. But we see as overall survival also, 5-year overall survival is quite decent, 44% in both the arms with very controlled toxicity. So this is also a good trial. This was another study published as a single-arm prospective study by Kim et al. From Korea. Actually, they designed this study. They intended to be a part of McDonald's, but because of the poor accrual, they converted into just a single-arm prospective study. And then they compared with the surgery alone arm operated in that in exactly same years. And again, we see the 5-year overall survival was definitely better. Even the disease-free survival and 5-year overall survival was better in the chemo radiation arm, adjuvant chemo radiation compared to surgery alone. And there was 20% reduction in risk of local recurrence with chemo radiation. So this was again an indication that yes, in the adjuvant setting, chemo radiation is superior to surgery alone and with limited toxicity. This ARTIST trial, I think it's been discussed, but this was again a landmark trial where they compared adjuvant chemotherapy with adjuvant chemo radiation. And stage T2 were excluded. And as we see, the compliance rate was excellent in both the groups. Grade 3 neutropenia was comparable. Grade 3 GI toxicity was also comparable in both the groups. And we see that at the median follow-up of 53.2 months, endpoint of overall survival was not analyzed, and 3-year disease-free survival was similar. P-value was not significant, though there was a trend towards better in CTRT, but 0.08 p-value, so which will not be considered significant. But we look at the disease-free survival in the lymph node positive patients. This is a subgroup analysis. It was 77.5% versus 72%. So there was a betterment in disease-free survival in the chemoradiation group compared to the chemotherapy group, indicating a better local control after sufficient observation time. This is at the like 5 years. So this is again, radiation was with primitive techniques of APPA fields, which is not practiced anymore. And so we see there was, though it was not significant disease-free survival benefit, but in this paper, you must concentrate on this. Another just graph was published, printed in JCO, but it was never there in the discussion or in the conclusion. So if we look at the another subgroup analysis, what they did the stage-wise, like stage 1B2 versus stage 3 and 4. Then now we start seeing the difference, which is clear, of 11%, which is p-value is also significant, where chemoradiation was a winner compared to adjuvant chemotherapy, where stage 3 and 4 were concerned. So there was there was a trend to, we can say, though it is not powered enough and we cannot say for surety that chemoradiation is superior to chemotherapy, but in this subgroup, yes, it indicated. Therefore, ARTIST-2 trial is subsequently randomizing patients, only the node positive patients, to compare adjuvant chemotherapy with adjuvant chemoradiation. And another trial published, Chinese trial with a good D2 resection. They randomized 380 patients to adjuvant CTRT versus just chemotherapy 4 cycles alone. And 55% patients had more than 2 positive lymph nodes. Again, we see that there is disease-free survival was superior in chemoradiation arm compared to chemotherapy, and there was no difference in overall survival at 5 years. So, so who benefits actually from the adjuvant chemoradiation? In the meta-analysis, where we see, but the meta-analysis, you look at the studies which are majorly were 116, that is McDonald's, and this Chinese trial where chemoradiation was given. So RT overall compared in the adjuvant setting compared to the observation alone is the winner. So like when there's only surgery or there's a suboptimal surgery, definitely chemoradiation has a place. But when compared directly with chemoradiation versus chemotherapy, there is no direct evidence that chemoradiation is superior. So, impact on nodal dissection. So if there is definitely substandard nodal dissection, then chemoradiation, again, we see that it can be given and it can be practiced safely. So, and there is no interaction between the benefits of RT and extent of nodal dissection. So therefore, there is RT is associated in this meta-analysis with approximately 20% reduction in risk of disease relapse and death from any cause. And efficacy of RT did not vary with the geographic region. Then what about adding post-op chemoradiation to the patients undergoing perioperative chemotherapy? This was again answered by Critics trial, which was published now recently it has been published. This was a trial design where perioperative chemotherapy followed by surgery and more chemotherapy in one arm, and then chemotherapy followed by surgery and chemoradiation in the trial arm. And the results were published in 2016, where we see there was no benefit either in overall survival or progression-free survival between the peri-op chemotherapy alone versus peri-op chemo and chemoradiation. So definitely it is clear that there is no benefit of adding chemoradiation to adjuvant chemoradiation to those patients who have already received NACT and surgery. So therefore, in ESMO guidelines, we have all these options, like if the patient presents operable, they can undergo perioperative chemotherapy followed by surgery and more chemotherapy, or upfront surgery followed by chemoradiation. And you can choose the treatment where it depends on which part of the globe you are. So in US, still many of the centers, they are practicing adjuvant chemoradiation. In Korea, Japan, and Northeastern, and in the Eastern countries, surgery and only adjuvant chemotherapy. In India, actually, it's institutional based practice, peri-op chemotherapy or adjuvant CTRT, which either of it I think is not wrong, and whichever it's a physician's preference, and it can be delivered safely. So in today's you can choose, but as we were discussing by Dr. Suman again, so what is the applicability of data on the Indian population? So can we replicate artist kind of outcomes? Are surgeons capable of, or the pathologists are capable of dissecting this many numbers of nodes? Look at the number of nodes, 40, 45, and D2 in the D2 dissection, whereas in US it is less than 15. Our institution, it's maximum around 15 to 20 median nodes dissected, and there's always an argument between the surgeons and the pathologists that who has not done a good job by having. But I feel it's just the biology, and these kind of nodal yields are a reality, and we may never meet this ideal figures of 40 and 45. And so lymph node ratio does matter. And again, this we just in the previous presentation, we were discussing about what is our Indian histology subtype. So these are the publications. Our Indian histology subtype actually tilts more towards the intestinal type in more than half of the patients. And that may help us to decide the treatment in some way, in some manner. And we have more predisposition for because of this intestinal histology for local and nodal recurrence. So therefore, we may be justified in preferring chemoradiation in some set of patients. And about look at the survival curves. How our Indian survival curves, do we match with the Korean ones or the US ones? You know, so you can see the excellent survivals. They have a screening program, they have early tumors, their outcomes are better. Look at the survival, and our survival curves look like US survival curves or Chinese survival curves. You know, so again, it helps, you know, where do we stand where Indian patients are concerned. Now this artist 2 will be I think published soon. We are waiting the results where they're comparing 3 arms. S1 is their own indigenous drug, and which is like somehow we feel that it gives a better outcomes than the normal 5FU. So arm A is S1, arm B is they have added oxaliplatin to S1, and arm C is S1 with chemoradiation of 45 gray and more chemotherapy. And recently they published one outcome from this on this trial. I think accrual is over, and this was recently published in December 2020, and this was the effect of baseline sarcopenia on the adjuvant treatment for D2 dissected gastric cancer. And what did they see? That there was no benefit in, if you look at the overall survival or the recurrence-free survival. If you look at the whole cohort, there's like both the arms are doing similar. But when they saw that patients who had baseline sarcopenia, chemoradiation was clearly a winner. So where a recurrence-free survival is concerned. So definitely we will be looking forward for the final results. But when we look at our patients in our Indian clinics, we see, I think 70%, 60 to 70% patients are having baseline sarcopenia. So as a radiation oncologist, there's again opportunity for us for us to offer them a better treatment where they're already so compromised, and it may be better than just adjuvant chemotherapy. So therefore, this is a very promising arena to overcome and study onto. And I would like to conclude that for those patients who have already received pre-op chemotherapy, there is no benefit in adding chemoradiation as per the critics trial. But for patients who undergo upfront surgery, post-op chemoradiation can be recommended in suboptimal nodal dissection, R1 resection, cut margin positive, node positive without preoperative sarcopenia, and this as per the artist 2 results, this is, I think we can give in some select group of patients, we can practice chemoradiation, adjuvant chemoradiation. Thank you so much.
Thank you, Reena, for this clear and extensive discussion on adjuvant radiotherapy. Now I call upon the discussions. There are 3 radiation oncologists for the discussion of this topic. Dr. Piyush Kulasista, I request him to come to the discussion. He is eminent radiation oncologist in Delhi. Dr. Shuman Das, consultant radiation oncologist, Apollo Hospital, Visakhapatnam. And Dr. Arun Lal is a consultant radiation oncologist, MVA Cancer Center. All 3 are requested. Over to you. Thank you.
Congratulations, Dr. Reena. Very well covered topic and very nicely presented. But you know, with evolution, we have seen surgery, then we added chemotherapy with surgery, and now chemotherapy plus radiotherapy plus surgery. But you see, in our Indian scenario, you know, it is very difficult to for the patient to tolerate all 3 modalities. Patients, mainly our patients are from the lower middle class, nutrition is poor. So like, what is your experience during treating these patients, whether they are able to complete the treatment or not? Because we are really facing a lot of problems. Patients, you know, they don't come for the 2 weeks or 3 weeks, then we do gap corrections and all. So what is your measures to overcome all these difficulties?
So excellent question, and this is a practical reality. And we published, I think Supriya, my colleague, she published in 2015. Okay, so So the patients, so at our institute, most of the time we are practicing perioperative chemotherapy only for the patients who undergo upfront surgery for various reasons, or who have suboptimal nodal dissection, which is also a huge number, because either they get operated outside or the nodal lesion is not so much. So these are the cases which we do get. And I feel as a radiation oncologist, the onus lies on us to learn the proper technique. So we published our results in 2015, where we compared our IMRT and 3D CRT. I must tell you, IMRT looks much more easier and is easier, but we have to keep certain things in mind. And if we plan our radiotherapy well, our I think tolerance rate for chemoradiation and completing chemoradiation at least is more than 80-85%. So it all depends on the safe technique, and there are contouring guidelines. And for ICRO, I've been taking regular lectures as teaching lectures on the post-op chemoradiation contouring. So if we do a very safe contouring, and even 3D CRT is challenging, but it is very easy to manage and achieve those doses and the OAR doses, but it is very challenging for the physicists. So as a radiation oncologist, first ourselves, we should be very sure about our contouring, our volumes, the liver OARs, and what kind of beam from which angle to be put. It is all very important, but I think it is a very, very doable. I've never, I started doing this chemoradiation, adjuvant chemoradiation, right, in 2006 or 2007. Barring one or two patients who've had grade 3, grade 4 toxicity, it's almost non-existent in our center. So it is very important for us to learn the proper technique. I would not stress more on this.
Thank you.
I do agree with Madam that in the present day with the techniques, the treatment is definitely very much well tolerated, especially after the use of capistavin in the concurrent setting. And one thing I wanted to just highlight about the incomplete nodal dissection that Madam has very clearly said. Once in incomplete, that what would be the number of lymph nodes that we would call it as incomplete dissection. And as far as one of the studies, less than 15 nodes, Madam has mentioned, and few of the articles, there is 16 nodes. In fact, Reena Madam can give a better light on that.
Yeah, so at our center, anything less than 15 nodes, median nodal lead of nodes, we consider it suboptimal nodal dissection, because it is just not possible, because 15 nodes, if you dissect the perigastric nodes only, you can get more than 15 nodes. So if it is less than 15 nodes, that means they've not even gone up to the rectopancreatic level. They have just they've not even properly dissected the perigastric nodes. So it is, and though the surgeons may say anything, but you have to also push your pathologist to go back to the specimen and try to get more yield. Sometimes we may just blame the surgeon unnecessarily, because where the pathologists have been lazy. Yeah.
In the Indian context, many times we also have to have full trust on our surgeon and also the pathologist. Not all the centers have got good pathologist or very good surgeon with caliber to do gastric surgeries. So those things also need to be considered in Indian context. Thank you.
And yes, also the stations matter.
Yes,
so you have to make sure that they have gone back
properly.
To remove the portal. Even most of the surgeons don't open the porta. Portal nodes are not removed, which are supposed to be removed in D2. They have to remove up to L1, L2. They don't go down also sufficiently. So stations also matter. So you have to it should be in a joint meeting with the surgeon and the pathologist, and they should be frank enough to say that what exactly was done.
Thank you.
And just to add to what Dr. Reena ma'am was telling, this is Dr. Arun here. Regarding the artist 2, I think there were two
concerns. One was that it was intended to recruit around 900 patients, but eventually I think they could recruit only around 500 patients to all the 3 arms. Secondly, as ma'am has rightly shown, the 3-year survival in almost all the Korean trials, the 3-year survival is close to 70%, and the same thing with the Japanese. But for us, it is always, I mean, if you get 40% 5-year survival for your stomach cancer, I think we will all be very happy. So the way the disease behaves in Korea and Japan is definitely different from what we actually see in our land. And my question to Reena ma'am is, Top Gear results are expected soon. So do you think we will be shifting towards a pre-op regimen in stomach, or how do you see?
Yes, that was not in my talk, so I didn't cover that. But yes, I think Dr. Wong, after me, she will be talking extensively about Top Gear. And as we hear from the co-investigator who are our friends, chemoradiation is coming up to be a very promising arm. So definitely, I think there will be a change of practice after the Top Gear results.
Thank you, Dr. Reena, for nice explanations and
thank you.
Talk. And thank you, Dr. Arun, Dr. Suman, and Dr. Pulasista. Thanks for your time and patience and discussion. Thank you all.
Thank you, Dr. Reena, for a wonderful lecture. And we invite our next speaker, Dr. Vamsi Krishna, who is a senior medical oncologist, Apollo Hospital, Hyderabad. And he's going to talk on immunotherapy, perioperative chemotherapy in stomach. Dr. Vamsi, please.
Good evening. I hope I am audible and my screen is visible.
Yes, you are audible.
Thank you. Thank you so much. So thank you very much. And it's a great initiative, the GI Oncology Group. This is something that we have been wanting and we really need in India. Dr. Reena has just very lucidly talked about all the post-operative part of the radiotherapy. Unfortunately, I believe now is the time for perioperative. Either chemotherapy or chemoradiation or something as a combination. But that is what I would be talking about in the next 15 to 20 minutes. A little bit of an update in my CV. I'm no longer in Apollo Hospitals. I have joined AIG Hospitals, Hyderabad, Institute of Oncology. So that's just an update to the organizers. Now, what we want to discuss when we see stomach cancer is when we are looking at surgery alone. I think it's a given that other than stage 1A, 1B, possibly 2A, everywhere we are not. Yeah. So other than these early stages, everywhere the outcomes are not great. The 5-year survivals in the stage 3, stage B, 3B, C4 are less than 20%. And even in the stage 2B, 3A, the survivals are not great. So definitely we do need treatment in addition to surgery for most patients. More than 50% of gastric cancers are diagnosed as a locally advanced disease, and the prognosis of those patients who are operated and then have a node positive status remains quite poor. Patients with gastric cancer do get both regional as well as distant metastasis, with the most important prognostic factor being the lymph nodal spread. This is considered to be due to various things. We have seen what micrometastatic disease is there. We have talked about adequacy of the surgery, D1, D2, and more. Basically, the whole message goes out that you need to incorporate more therapy, either chemotherapy or radiotherapy. Now, when we look at the nomenclature, by and large, this is something we are now comfortable with. When we talk of gastric cancer, we are talking about the fundus, the body, the antrum. Esophagus and gastroesophageal are more or less now understood to be a different part. So for the rest of my talk, I would be focusing on the gastric cancer part. That's what was told to me. I'm not really looking at the esophagus and the gastroesophageal because that's kind of a combination that's kind of different from how gastric cancer behaves. The challenge, of course, is all the trials have actually included both in varying proportions, and that makes it a little difficult to make our decisions regarding the aims or regarding the perioperative chemotherapy. So in short, what is the benefit of giving a neoadjuvant chemotherapy or so-called perioperative chemotherapy? Of course, downstaging the tumor is important. Increasing the R0 resection rate is crucial. If we go back to the earlier trials, the early 1990s, the 2000s, where only surgery was done, close to 20 to 30% of patients did end up having a positive margin or in either R1 or R2. So reducing that rate, increasing the R0 resection rate becomes very important. Overall survival is, of course, what we are looking at. Now, it's a no-brainer when the tumors are locally advanced and you probably cannot operate. But aside from this, what has been seen, as I'll show you in the next few slides, is that even in those patients who are so-called early stage or just small nodal burden, even there, when you give neoadjuvant chemotherapy, it improves the overall outcome. And that is where we are now. When you look at the evolution of this, starting from the 2002, when you had the 0802 trial, then of course we had the 0805 trial, then in 2006, we had the MAGIC study. Now, the MAGIC study, which I'll be showing you in some detail, was basically chemotherapy, surgery, followed by chemotherapy versus a surgery alone arm. Now, when you look back at it from today, for me, this study with a surgery alone arm is definitely inadequately powered. You need to give surgery followed by adjuvant chemo. You need to give some other type of protocol, but surgery alone is definitely not sufficient. Later, we had the FFCD trial. Now, again, this trial looked at one arm containing chemo and surgery versus the other arm containing surgery alone. The next study is the CROSS study. Now, CROSS also had the same concept where you gave neoadjuvant chemo and radiation followed by surgery versus surgery alone. So, for me, till 2012, all these studies, the comparator arm is a little weak. You're doing only surgery. It was in 2017 when the FLOT study came, where you really had two well-balanced arms. You had chemotherapy, surgery, and chemo followed versus chemo, surgery, and chemotherapy. So that is why probably this trial has become much more popular. Coming to the first study, the Mrc Magic Trial. Now, this Magic Trial included stages 2 and above, gastric, gastroesophageal, and lower esophageal, esophagogastric adenocarcinoma. See the combination here? Though in this study, it is primarily gastric, which is 74%, but then you did have the other groups as well. So, patients got ECF. Now, remember in this, the 5FU protocol was a continuous 21-day protocol, which personally I have never used. But of course, later on, we could say that capecitabine alone is good enough. So 3 cycles of that followed by surgery with a 3 to 6 weeks break. 12 weeks break was allowed here. So you're actually allowing 3 months for the patient to recover and then 3 cycles post-op versus surgery alone. That's your 2 arms. When you looked at the patient characteristics, when you're looking at chemo and surgery, in the surgery alone arm, now this is where I was talking about curative surgery. It was possible only in 66% of patients. Numbers slightly improved in the chemo surgery arm, but they also had a bigger number of others, which was probably what was curative as well. Now, interestingly, in the chemo arm, you found that there were more number of early stage and early end stage as compared to surgery alone. So basically, it told you that perioperative chemotherapy leads to tumor downstaging. So that is the key message from this trial for me, that you have a downstaging with chemotherapy. When you look at the progression-free survival, significant benefit, well separated, hazard ratio 0.66. Overall survival, again, hazard ratio 0.75 with an absolute gain of around 13% 5-year survival. So this laid down a marker, 36% 5-year survival. With surgery alone, remember, it's around 25%. Though the median OS looks not very impressive, 4 months. However, for me, this number is more important. Your absolute gain in 5-year survival. Now, coming to the second trial, the FFCD trial. Now, in this study, they use preoperative cis-5FU. There's no epirubicin. So, anthracycline, is it really going to add something or not, was what they were trying to address. Numbers are lower. There was an issue as far as the enrollment and accrual was concerned. You gave 2 to 3 cycles pre-op surgery and 3 to 4 cycles post-op. Again, looking at gastric, here was only 13%. Remember the first study I showed you, it was 74%. Here it's only 13%. The geo junction was around 62%. So in this study, again, looking at the YP stage, you found out that patients undergoing surgery had earlier T stage, earlier end stage. So confirming that your perioperative chemotherapy leads to tumor downstaging. Now, in this study, again, when they looked at the results, showed that there was a hazard ratio of 0.69 in favor of this chemo and surgery arm, and absolute benefit was 14%. So smaller numbers, but still confirming your 38%, what you saw in the MAGIC is something similar to what you're seeing in this trial as well. Now, there were some important lessons from this MAGIC trial, and though it looked good, remember in this trials, 10% did not complete the pre-op chemotherapy. 50% of patients do not complete their post-operative chemotherapy. So, though your trial actually says that you should finish post-operative chemotherapy 3 cycles, only 42% in the MAGIC study and roughly around 23% in the FFCD completed all the planned chemotherapy. So interestingly, despite having this much, they were still able to show overall survival benefit. And for me, the major reason why I think that could be done was also that the surgery arm did not have an adjuvant therapy arm. So whether that influenced this decision, the results, we are not really able to say. Now, after this came the 2017 paper of the FLOT. Now here, when you look at the reports, the most important one is this part, the medically and technically operable gastric cancers. We are not taking locally advanced trying to downstage here. We are taking patients who are technically operable. Now, it is difficult for many of us, especially when a surgeon sees the case, they find that it is just T3, T4, no nodes, the tendency is to operate. However, remember that that group was included in the FLOT study. So you have T2 to T4 and any, essentially anything that is T1 was excluded. Otherwise, anything which was node positive was included. Fairly simple protocol, FLOT, that is docetaxel, 5-FU, leucovorin, and oxaliplatin. Again, no anthracyclines. For 4 cycles, followed by resection, followed by FLOT 4. Here you used ECF or ECX, 3 cycles, resection, and again 3 more cycles. The primary endpoint being overall survival. So, when you looked at the number of patients who could undergo surgery, higher in the FLOT group, number of patients with a R0 resection higher, 84%, 94% here, both significant. So, perioperative FLOT increases the proportion of patients who undergo surgical resection, increases the R0 resection rate, without any increase in the morbidity and mortality. When you looked at the PFS and OS, again, significant benefit, 18 versus 30 months, hazard ratio of 0.75, but 12-month absolute improvement in PFS median, and a 13-month improvement in the overall survival with a good hazard ratio. So again, we spoke of 5-year results. In the ECF, we were talking of around 38%. This study, the ECF did the same. It is around 36%. FLOT increased it to 45%. And this to date remains the best results with your 5-year overall survival. Now, when you talk of treatment tolerability, preoperative chemotherapy, 90% in both the arms, surgery undergone in 94%. Important is this number, post-op protocol completed in 46% in FLOT, 37% in ECF, which means that patients treated with FLOT were more likely to commence treatment, and those who commenced treatment were more likely to complete their therapy. Is this what we see in clinical practice? By and large, I think most medical oncologists are now comfortable with FLOT. Pre-op, I think most of us are okay with it. Post-op, we are able to complete cycles in a significantly more number of patients. Importantly, the benefit of FLOT was not confined to a single subgroup. It included groups such as T3, T4, T1, T2, node plus or N negative, and those patients with or without signet cells, which are considered to be poor prognostic markers. So in all these subgroups, FLOT is beneficial. Do we have any data from India? I could not find too much data except this presentation, which was a poster presentation in the ESMO from Tata Memorial Center. Now, what they showed was comparing ECX, ECF versus FLOT. Not as a randomized study, this was a retrospective study. They found that those patients who underwent ECF EOX had 12.5% pathological CR, pathological tumor regression score of 0 or 1, in comparison to 25% with FLOT. 40% completed the complete treatment in ECF EOX, 60% completed the full FLOT. So again, this number for me is from India, and it is something which we kind of accept that 65% seems to be 60 to 70% is probably what we would see in practice. So is this post-operative chemotherapy low number really significant? When you compare two arms, you find that by and large, the post-operative chemo is given around 40 to 50% of patients, whereas pre-op chemotherapy is completed in 90%. So there are a lot of analysis which have been done. There is a meta-analysis which showed that this post-operative chemotherapy actually was significant. So there was initially a thought that if you don't give the post-op chemo, does it really matter since your numbers are so small? So there was a systematic analysis which looked at all the factors influencing the result outcomes, and they found that one of the factors which was independently associated was the post-operative chemotherapy. So post-op chemotherapy is important. You cannot simply neglect the post-op chemotherapy. So what about radiation? Is there anything which says that we can give pre-op chemo radiation? Again, remember, I'm talking of stomach. GE junction, we have the cross protocol, which is very well established now. For squamous, I think there's no doubt anymore or debate anymore. Even for adeno, both are reasonably acceptable. Lower esophagus, in fact, we would tend to go with a chemoradiation. I'm talking about stomach. So there have been multiple small studies. Better PFS was shown. Better results were seen in terms of responses. However, one study which kind of pushed it back was the critics study. Now, the critics study used pre-op chemotherapy in 3 cycles, followed by surgery, followed by chemo, pre-op chemo, followed by surgery, followed by chemoradiation. Now, this study did not show any benefit, so probably adding chemoradiation over chemotherapy is not really useful. And this was already presented by my previous speaker. So the critics 2 study is probably what we are going to look at, because here they're using pre-op chemotherapy versus pre-op chemo followed by chemoradiation followed by surgery, or only chemoradiation followed by surgery. So this study is actually going to really kind of hint towards what's the role of radiation. Of course, we have the Top Gear coming in, which will also tell us whether pre-op chemoradiation is genuinely useful or not. Now, these guidelines were already presented by my previous speaker. So by and large now, any operable gastric cancer more than T1N0, again highlighting that more than T1N0, T1 you can actually do local treatments as well or direct surgery, but more than T1, the preferred pathway as per ESMO is going for preoperative chemotherapy, followed by surgery, followed by post-op. For any reason you do surgery, well, you can go with adjuvant chemoradiation or adjuvant chemotherapy. You can have a lot of discussion on that, and that is a thing not yet settled. What about NCCM guideline? They kind of give the same picture. If you have T1A or T1B, go with surgery. Any T2 or higher, perioperative chemotherapy is category 1 and preferred as well. So the day today is of perioperative chemotherapy. So what are the trials on targeted therapies and immunotherapy? Though my topic does speak of immuno as well as targeted therapy, there's not really too much happening there. One part which we are really looking at is the HER2 positive subset. Now, in the HER2 positive subset, metastatic, we know that trastuzumab works. In fact, we have recent data even on the PDM1, which showing some benefit. So what about perioperative treatment? Small phase 2 studies, which have included very small number of patients, they did show that if you add trastuzumab, you might end up getting a better PAT-CR rate, which could translate into a potentially better R0 dissection. But there are some big trials ongoing. The Petrarca and the Innovation will look at trastuzumab plus pertuzumab and see if you can achieve a better overall survival in those patients. Similarly, you do have some trials on bevacizumab and ramucirumab. Frankly, I am not too keen on these trials. The bev and is not a great success in anything except maybe second or third line stomach. Ramu has worked in second line stomach. First line stomach metastatic was a failure. The new kid on the block, immunotherapy, which is used practically everywhere, except probably stomach, where the data even in metastatic is not so great. The exception being probably the Nivo data, which is somewhat encouraging. But there are 2 trials going on. The Keynote 585 is a phase 3 study of perioperative chemo with or without pembrolizumab, a fairly simple trial which follows pembrolizumab for overall of 14 cycles. So we'll wait for these results. We do have the Vestige study, again an adjuvant immunotherapy with resected patients, following pre-op chemotherapy. So this is one more that we can look forward to. Overall, however, my take-home message is FLOT is the new gold standard treatment for patients with operable and locally advanced gastric cancers. In patients who are not suitable for this triplet chemotherapy for medical reasons, doublet can still be considered. It can be either cis or auxiliary based. 5-year projected OS is around 45%, so we do have work to do. Probably integrating radiotherapy is something that is going to improve this. Immunotherapy, well, I have my doubts. I am not sure it's the right way to go ahead. So thank you, and I look forward to a good discussion.
Thank you, Dr. Vamsi, for a wonderful lecture and sticking to time. Now I invite discussants, Dr. Nidhi Gupta, who is Assistant Professor, Department of Radiation Oncology, Government Medical College and Hospital, Chandigarh, Dr. Sudeep Das, Consultant Medical and Hemato-Oncologist, Netaji Subhash Chandra Bose Cancer Hospital, West Bengal, and Dr. Sadvik Raghuram, who is Consultant Department of Medical Oncology at Medicover Cancer Institute, Hyderabad.
Okay. So good evening, everyone. I'm Dr. Nidhi. Dr. Krishna, that was an excellent talk, and you very nicely summarized all the evidence for perioperative chemotherapy. My question to you is that the concept of perioperative chemotherapy says that post-operatively we again add the same chemotherapy regimen. So in case the patient is not responding well to the perioperative chemotherapy, we do not see a pathological complete response, or for that matter, we do not see a good response on pathology. Is it wise enough to continue with the same chemotherapy regimen to which the patient has not responded, or we should consider for a change of chemotherapy? Or alternately, we can consider for some biomarker preoperatively like a PET scan. And, if we find that the patient is not responding well to perioperative chemotherapy, we may bring in chemoradiation. So, sir, what will be your take on this?
So again, very good points you have made. Answering your first thing, see, the PAT-CR rates are not more than 10% anywhere in stomach. You're getting 10 to 12%. So I think the age like breast where we go for 50%, 40% PAT-CR and then decide your therapy, I think that's not really true for stomach. Again, the intent of perioperative chemo in stomach is to kind of downstage the disease. It doesn't mean to give a PAT-CR. Having said that, increasing the PAT-CR by giving even more chemotherapy, I don't think that's going to work. We really don't know that you change the chemotherapy later, it will help much, though it's a good session, but what do you change it to? The drugs which are useful are probably in FLOT, you're already using your taxanes, you're using your oxaliplatin, you're using your fluoroprevalines. You will have to change to either another taxane, which doesn't make sense, or go for anthracyclines, but when you know that anthracyclines don't work, it really doesn't help much. The idea what you're saying of using a biomarker is good. Again, what biomarker, we don't know. So I personally feel what will be really integrating is either radiotherapy upfront rather than later, because the critics did show us that adding chemo radiation doesn't add extra benefit over chemotherapy. And you're having only 50 to 60% of patients actually completing chemo. So adding chemo radiation to chemo post-op, I'm not sure how much useful it's going to be. So that's my thoughts on it. But like I said, things are changing and we will see how it happens.
So, and the kind of, you've said that a lot of patients are unable to complete the post-operative part of the perioperative chemotherapy. So is there any cutoff you keep for the time intervals that, 6 weeks, 8 weeks, beyond which if it is delayed, you think now it's not, it's not going to give any advantage to treat this patient?
So that's again a very good question. So normally if you see the Magic Trial, they let 12 weeks gap. Again, FLOT has allowed 6 to 8 weeks if I'm not mistaken. So in stomach, I am not very aggressive that I need to start within 3 weeks. I would probably be okay to 8 to 10 weeks also, but I would try to give my treatment at some point. Again, it's 5-6 months down the line, I will not give. But before that, probably my cutoff will be around 10 weeks or 8 to 10 weeks. I would be able to, I'm okay to wait till then to give it.
Okay, thank you, Dr. Krishna. Do we have somebody else?
Yeah, Dr. Sadhvi. Yeah.
Yes, sir, it was an excellent talk. Everything has been covered so extensively. So my doubt is like continuation of what Nidhi ma'am has just asked. Would the follow-up schedule be more extensive for patients who are poor responders, considering the risk of recurrence would be a bit high? And if you have an extensive follow-up, would that even benefit them?
Extensive follow-up or extensive therapy?
No, sir. Extensive follow-up, more imaging during the follow-up period.
So I don't think there's any tumor where more imaging has helped ever. So, I mean, honestly, that's my take on it. So I don't think imaging or a follow-up goes follow well. Prognostication, it does matter. We need to counsel the patient that, look, there's a higher chance of disease coming back. Regarding, again, longer therapy, we are finding difficult to tolerate even the basic chemotherapy. So I'm not sure more therapy would help as well. A good idea would be if you can put somewhere, for example, a HER2 positive, you add your trastuzumab and give it for 1 year, like what we did in this. Somewhere, I think that's the line we have to go to, but trastuzumab is present only in 5%. Perhaps an MSI high, go with an immunotherapy. That's one way of looking at it. So I think we need those biomarkers, something that is well tolerated, not just effective.
And
Dr.
sir,
Ramsey, there are 3
can I ask
questions.
another question?
Yes, sure, go ahead.
I'll ask the questions in the chat box itself. So what is your opinion on total neoadjuvant chemotherapy? Considering all the trials which have been discussed show only like 40 to 50% patients are able to complete the adjuvant chemotherapy. So is there any role of completing all the chemotherapy before surgery?
So that's what Critics 2 is looking at. That's what Top Gear will look at. That's what we are looking at. I think that is a good way to go forward. Especially for esophagogastric, of course, it is the good way to go forward. For gastric, I think that is also a good way. So we'll have to wait for the trials. So I think all the 3 questions are on the same topic, excepting one which is adjuvant. So I guess the adjuvant one, maybe the next speaker can address.
And Dr. Krishna, we request you to please attend the questions that has been asked in chat box. And Dr. Reena, please.
Yeah.
Thank you.
For Dr. Reena, I think there is one question that what is the ideal sequence of chemotherapy and radiotherapy in the post-operative setup of gastric cancer who have not received neoadjuvant chemotherapy, but with inadequate nodal dissection? There is a question in the chat box.
So actually, there is no study looking at the sequencing, but what we do generally follow is 2 cycles of chemotherapy followed by chemoradiation and another 2 cycles of chemotherapy. But when there are R1 resections or like when definitely it's R1 resection, I would like to, as a radiation oncologist, I would like to first sterilize that area. So I would like to alter it, start with chemoradiation followed by 4 cycles of chemotherapy. This is what we can tweak it a little bit. That's all.
Thank you, ma'am. If there are any more questions?
Okay, I'll ask one last question.
Yeah, sure.
So, Dr. Krishna, so for the MSI status of the tumors, do you think that it is time to implement MSI into practice? Or the taxanes are going to be the game changer for gastric cancer and we just cannot, mimic the colon cancer?
Tough to answer. See, the MSI data for immunotherapy is mostly metastatic setting. So it has still not been incorporated in the adjuvant setting anywhere. So having said that, I think that's what is going to be tested and we'll have to wait for the results. Personally, if you ask me, I think it is something which seems to result, because the keynote 177 in colon is really interesting data with MSI high first line working so well. Whether that same thing can be replicated in the adjuvant setting, it's an open question.
Okay,
I think even in esophageal cancer, now there is data coming up for adjuvant nivolumab, isn't it?
There will be some data. I'm not aware of the exact data, but something must be coming up.
I request Dr. Sudeep to make a comment or if he wants anything to add to it. Dr. Sudeep Das.
Sudeep, move forward, yeah.
Okay. So, I request Dr. Manoj Gupta to please invite our next speaker.
Right. Thank you very much. So I think we are coming to the end of this session. Now the question is that how best we can apply these data on our Indian patients. That is what we are mainly interested in. And to answer this question, I invite Dr. Vinita Goyal, who will summarize the summary of these lectures, especially in Indian context. So over to you, Dr. Vinita.
Thank you, Chairpersons, and thank you, organizers, for giving me this opportunity. I'm not able to share my content as I'm traveling. I request organizers to kindly show my slides. So I think all the 3 speakers before me have extensively, next slide please, have extensively already covered the topic so well that I have very little to add to whatever they have already contributed. So earlier on, we were regularly using the morphological classification for gastric cancers. And although the WHO classification did come in 2010, but as Dr. Suman has rightly said, we never followed it because it added little to our clinical practice. Rather, we were all still following the Lauren classification, which came way back, but was more practical. Now from here, we are going towards morpho molecular classifications of gastric cancers. Next slide, please. So there are several classifications, molecular classifications, which have already been shown. This is the one by TCGA. Next slide. Then there is a separate one which is proposed by the Asian Society. Next slide, please. Yeah. So, this is a second classification, and then this is the third classification. This third classification, which is based on the immunohistochemistry and ISH, is mainly proposed by people who find that doing NGS may not always be practical. So this is something which might be more relevant in our Indian subcontinent, where a lot of patients are not able to do NGS for routine molecular stratification of gastric cancers. So when I look at all these classifications, I find that they are majorly similar with minor variations. As of now, we do not have any consensus as to which one is the best one or which one is the correct one. But we have to still wait to understand these classifications and their implications a little better. But I would say that they're relevant. We cannot say that they're irrelevant because they provide prognostic as well as predictive information to response to therapy. Next slide, please. This is a slide which is showing that some of these molecular targeted therapies can be chosen based on the molecular subtype of the gastric cancers. So that is why I say that knowing the molecular subtype might help in a difficult situation, especially in a metastatic gastric cancer, not so much right now in the adjuvant setting. Next slide, please. Change the slide, yeah. So this Suman has already shown that based on the MSI status and deficient MMR status or PDL1 status, we can predict the response to therapy as well as prognosis. Next slide, please. We all know that the intestinal subtype of gastric cancer has more local recurrences. Oh, I'm sorry, this slide has come. So there are still a lot of issues in implementation of biomarker-driven treatment. The main issues which makes us practically difficult to use it in everyday practices because of the low prevalence of the actionable targets and the known therapeutic efficacy. The greatest challenge in my mind is the tumor heterogeneity. Within the tumor, there can be several different molecular subtypes which might overlap, which makes it very difficult to choose the right kind of pathway and therapy. Then there is an impact of ethnicity also. For example, Asian versus non-Asian gastric cancers may have different molecular signatures. Next slide, please. This has already been covered. Next slide, please. So my take-home message regarding molecular classification is that survival outcomes for gastric cancers are still very poor. Improving outcomes is still a major challenge for the oncology community. Gastric cancer is no longer a single disease driven by the TNM staging and D2 dissection. Rather, it's a spectrum of disease. We are certainly moving gradually beyond TNM staging and morphological classification. And it is the high throughput technologies which are providing us with a lot of valuable insight into molecular classification, and which probably in future will also guide us into the novel treatment strategies. As of now, there is no definite evidence to implement molecular subtype-based differential in the treatment pathways. There are some institutions which are already using immunotherapy based on results of various basket trials in the metastatic gastric cancers. Next slide, please. So we are not there yet. It's a work in progress. We need therapies which will be effective against multiple pathways rather than single pathway, because the tumors are generally very heterogeneous. We need more effective biomarkers to identify what is going to work for a particular patient. Till then, I want to again emphasize that in view of heterogeneity of the tumor, it is not only important to send sample for NGS, it is important to do adequate or generous tissue sampling. There are papers which recommend that minimum 6 biopsy samples should be analyzed together to identify the various pathways which might be involved. We have to wait for more data, but I would urge all radiation oncologists that although we do not have the correct consequence of the molecular pathways on the radiation therapy delivery, but we all have to still, be there, know it all, so that we have in future more data which can guide us about radiation therapy planning based on the molecular subtypes. Next slide, please. Now, coming to the role of radiation therapy for gastric cancer, there are two trials, Critics and Artist-2, which have not shown any additional benefit of postoperative radiation therapy after gastrectomy, D2 gastrectomy and chemotherapy. But there are still several less understood factors. For example, what is the implication of lymphovascular invasion or perineural invasion, or the sarcopenia, which was mentioned by Dr. Reena, which is preoperative nutritional index of the patient. We do not know the implications of tumor microenvironment and molecular subtype. So when somebody tells you that Artist-2 and Critics are negative in terms of the benefit of postoperative radiation therapy, just remember that right now we only know the tip of the iceberg. That information is very superficial. I think it is in future that we will have a better information about this. Next slide, please. So as of now, as has been emphasized by previous speakers, I would say that postoperative radiation therapy still has to be practiced selectively after a fair amount of discussion in a democratic multidisciplinary tumor board, and is certainly indicated for patients who have margin positive disease, patients who have T4 disease, patients who've had D0 or D1 lymph node dissection. In intestinal type of gastric cancer, we are more inclined to give radiation therapy. There is also more thought to give radiation therapy when the patients have extensive perineural invasion or lymphovascular invasions. If there are tumors in the pre-pyloric or pyloric region, your surgical oncologist might tell you that getting adequate margin from the pancreas or retroperitoneal part of duodenum is more challenging, and you might still consider radiation therapy for these patients. Next slide, please. Now, there are patients who get perioperative chemotherapy followed by surgery. For them, my indication of adding postoperative radiation therapy would remain similar to what I said in the previous slide. But in addition, if your patient has minimal response to NACT, which you can evaluate based on the TRG grading, then you may consider them for postoperative radiation therapy, knowing well that the chemotherapy has not done its job well. Next slide, please. At the same time, preoperative radiation therapy, I think this is already covered by Dr. Vamsi, who clearly said that a good number of patients, 2/3 of the patients could not take their postoperative adjuvant chemotherapy in the above mentioned trials. So, and right now, NCCN labels that preoperative CTRT in gastric cancers is a 2B recommendation. We have to wait for the results of the future TopCare and Critics 2. Right now, SGPGI in our own country is also doing their own study on the same lines. We also have our own small institutional experience. For example, patients who were not fit for preoperative or perioperative chemotherapy and were not operable were given preoperative CTRT after explaining it to them. And we find that the results are encouraging. Our surgeons are also feeling confident in operating these patients and do not face undue complications. Next slide, please. And at the same time, I would say that let's not all forget that for unresectable non-metastatic gastric cancer, for palliation of bleeding masses, and otherwise also, even if the patient is not very symptomatic, there are multiple studies, including National Cancer Database, which has shown that CRT rather than chemotherapy is better for these patients. Next slide, please. So regarding the third talk, which was about perioperative chemotherapy, I'm glad that the FLOT is better tolerated, because ECF was really not tolerated by our Indian patients who do not have very good nutritional status quite often. And I think it is the preferred regime. I completely agree with Dr. Vamsi. And like many others in the audience, I also feel that gradually the world is moving towards total neoadjuvant therapy approach in gastric cancer, although we will know that with the future trials and results coming up. So that's all from my side. Over to organizers.
Thank you, Dr. Vinita, for nicely summarizing all the talks, especially in context of our country. And I think we are coming to the end of this session. And I can only say that I thoroughly enjoyed all the speakers. They all were excellent, and all the talks were very, very informative. And on behalf of my fellow chairpersons, on behalf of myself, I thank organizer for having given me this opportunity. So over to you, Divya.
Thank you very much, sir. Before going on to next session, I would like to thank all the chairpersons, speakers, and discussants for being a part of this conference, and Dr. Vinita Goyal, ma'am, for giving a very crisp and informative summary of all the lectures. And for the next session, I invite chairperson.
Divya, can I interrupt? Can I just make a comment?
Yeah, sure, Dr. Kinjal.
So, it was a very interactive session, and, we had good talks from everyone. Very well summary by Dr. Vinita ma'am. I'll just like to urge everybody to join tomorrow also, because in stomach, it is very clear, though there are some controversies, but we are all very clear that perioperative chemotherapy is the standard of care right now. Tomorrow we are going to discuss about CA esophagus, and we have 3 international faculty tomorrow: Dr. Somnath, Dr. Edgar, and Dr. Pablo. And I just want to tell the faculty and the panelists and the delegates who are there that we are going to start early tomorrow. So we are starting at 5, and in esophagus we are going to have a lot of controversy. So it will be worth attending, and I request everyone to attend just like the way they are attending today. And anybody can give a comment on the chat box, after the questions. That is what, again, I would tell all my faculty to do that. So yeah, again, over to Divya, and thank you so much.
Thank you, Dr. Kinjal. I invite esteemed chairpersons for the next session, Dr. Neeraj Rastogi, who is a professor, Department of Radiotherapy, SGPGI Lucknow. Dr. Manish Pandey could not join. Dr. G.V. Giri sir, who is Secretary General Roy and Radiation Oncologist at Shri Shankara Cancer Foundation, Bangalore. Dr. Kishore Singh, Medical Director and Professor and Head, Department of Radiotherapy at Lok Nayak Hospital, Delhi. And sir is also Editor-in-Chief of JCRT. Over to our esteemed chairpersons for the next session.
Good evening.
Thank you, Dr. Divya. Now is the multidisciplinary tumor board is the need and hour. So for this, I invite Dr. San Paul, who is the consultant radiation oncology in Apollo Hospital in Kolkata. Now for the discussing the multidisciplinary tumor board. Over to Dr. San Paul, please.
Thank you, chairpersons. Thank you, organizers. Thank you, all the faculties and delegates. So today we are having the second case discussion now, and we have a star panel: Dr. Sameer Batham, Dr. Upasana Saxena, Dr. Abhishek Kakru, Dr. Shikha Goyal, Dr. Saikat Gupta, and Dr. Bhavna Sirohi. And I'm sure that no one needs any introduction. All are very eminent oncologists. So now I am sharing my screen. And straight away we'll start discussing the case. So give me a minute. Yeah. So good evening all. So today we have our first case, that is a 50-year-old male with no comorbidities presented with complaints of discomfort in umbilical region after food for 5 months, which did not improve with medication, for which he was evaluated outside. An upper GI endoscopy shows a growth seen at the GE junction extending up to 2 centimeters of cardia, and a biopsy was taken which shows moderately differentiated adenocarcinoma at GE junction. So now my question to the expert. So to Dr. Sameer, what further investigations do you suggest in this case?
So good evening, everyone. So for this patient, as the biopsy, we have the biopsy and the endoscopic finding. Next step would be the imaging. And I usually prefer, especially in adeno-C, I always prefer a PET CT or at least a CT thorax and abdomen. So this would be my next investigation.
Okay, so Dr. Shikha, do you suggest anything else other than this? Dr. Shikha Goyal or Dr. Upasana, are you there?
Yeah, Dr. Sain, can you hear me now?
So do you think an endoscopic ultrasound is also necessary for staging the disease?
Endoscopic ultrasound can be done, but your endoscopy itself would give you some information on the extent. Only if the surgeon is planning surgery upfront and wants to rule out nodes. In that situation, an endoscopic ultrasound can help map the depth of the disease as well as any esophageal and perigastric nodes in that region.
Okay, so I have one question for Dr. Saikat Gupta, who is a surgical oncologist. Sir, do you think a diagnostic laparoscopy is necessary in this case? Dr. Saikat Gupta, sir? Is he here today?
No, sir, he could not join, sir.
Okay, then Dr. Abhishek, what is your take on this? Is Dr. Abhishek Kakru there?
Yeah, I'm there.
Yeah.
Laparoscopy with biopsy and washings. So I am a medical oncologist. I won't be the right person to answer this, but I would be happy with a PET.
Okay, so Dr.
What I
Bhavna?
feel, if it is stomach, I'm sure.
Yeah, if it is a stomach, I would do it.
Definitely.
I would,
But
more
not
than
for a
T2.
G.
But for G, you're looking at a G junction, right?
Yes.
Okay, so Dr. Bhavna, do you have any other comments to make? Dr. Bhavna Chidoi, ma'am.
I think one can consider a diagnostic lab, but the pickup rate in GOJ tumors is almost 5 or less than 5%. You could also consider doing, I'd be very happy with just a CT chest, abdomen, pelvis. And I would also, given the recent data, I would consider doing MSI testing as well.
Okay, thank you, ma'am. So we have almost a consensus that yes, in EUS can be done, a CT scan, and MRI. Do anyone is for MRI? Any role of MRI in this case?
I think no role for MRI.
Okay, so a PET CT scan and a laparoscopy. So as you have already said, for T3 or greater tumors, diagnostic laparoscopy, and if clinically suspicious nodes without distant mets on imaging, and if there is visible peritoneal mets, we can take a biopsy, we can take a washing, and a positive washing cytology makes it a M1 disease. So the patient undergone a CCT abdomen and thorax with a concentric thickening in the lower end of esophagus, G junction, and going into lesser curvature of stomach with perigastric nodes and peri-G junctional lymph node, total 2 in number, and there was no metastatic disease in the lung. So your stage is CT3 N1 M0 disease. So now the question to Bhavna madam, what should be the treatment protocol?
So I think if this is a fit person, I would consider perioperative chemotherapy, and my regimen of choice would be FLOT.
Okay, Dr. Shikha Goyal, do you think any role of pre-operative radiotherapy or radiotherapy in this case in any way?
The CROSS trial has independently tested preoperative chemoradiation. And I recently there's no head-to-head comparison between FLOT and CROSS, but I believe there is a trial going on, and the network meta-analysis comparing these two trials has shown similar survival outcomes. So both of them I feel are equivalent in terms of effect, but the fitness of patient and the expertise in a given center may decide what would be the best choice for that patient. I would place them equal actually.
So Sayan, can I say that I would disagree here? So I would say that, with CROSS, the surgical mortality was higher. And with CROSS type of treatment, your chronic toxicities are higher, especially strictures and pneumonitis as per the trial. I mean, they have equivalent path-CR rates, both of them. With perioperative FLOT, there is better tolerability and slightly more acute toxicity. You have 8 visits to the hospital compared to 23 visits with CROSS. And with COVID times, I would try and decrease the visits of the patient to the hospital.
Okay, well taken, ma'am. And anyone for upfront surgery followed by adjuvant treatment in this case?
So, if it is MSI high, the data looks so amazing with the individual patient meta-analysis. I think in India, we should collect our own data with MSI high, whether, one can avoid any sort of neoadjuvant treatment.
So, okay, so these are the trials already shown by Dr. Vamsi, that OE02 trial, the MAGIC, the CROSS, and the FLOT trial. And in his talk also, he has clearly almost established that yes, the FLOT protocol is now the standard of care. So this is CROSS trial, and we have a good number of G junction cases in this trial. And in the MAGIC trial also, there is around 14% of G junction, 12 to 14% of G junction cases. And this is the FLOT trial, which is now can be considered as the standard of care. So I'm not going to discuss it anymore. So this patient has received neoadjuvant FLOT regimen. So 4 cycles from 25th of September to 7th of November 2019. And then the whole body PET scan was done after chemotherapy, which showed thickening at the GE junction. And an upper endoscopy was also done, which shows a nodular lesion at the GE junction on retroflex view extending 1 to 2 centimeter into the stomach. And then he underwent an exploratory laparotomy proximal gastrectomy with esophagogastric anastomosis on 17th of December. And the HPR shows there is a residual tumor of 2 into 1.5 centimeter, poorly differentiated adenocarcinoma invading muscularis propria, and 3 nodes positive out of 15 nodes for metastatic carcinoma, LVI PNI not seen. Proximal margin was 1.4 centimeter, distal 6 centimeter. It was stage as YPT2N2 and suggestive of near complete response, score 1. He was taking liquids through phageal jejunostomy and was passing stool, and he received 4 cycles post-op FLOT chemotherapy, which was completed on 17th March 2020. And on PET CT scan on 25th of September 2020, there is a mild FDG avid gastrohepatic lymph node, para-aortic lymph node, and perigastric lymph node with increased size and appearance of metabolic activity. So EUS guided FNAC from perigastric node was done, which shows metastatic deposit, positive for malignant cell, and it's high grade. So now the patient's GC is fair, ECOG is performance status is 1. So what is the further course of management? So Dr. Bhavna or Dr. Abhishek?
Yeah, so you could get,
Yes,
you could
please.
get I think you could get an MSI HER2 done and decide on the next course of chemotherapy. We would already use FLOT. So you are basically have little choices now. Cyramza, paclitaxel, irinotecan, or any second line therapy, or if possible, maybe immuno or a HER2 positive treatment.
So I would use, I would do PDL1 CPS score as well.
So nivolumab, yeah.
Okay. So any role of radiotherapy in this case, Dr. Shikha, because the patient has not received radiotherapy ever?
This is already M1 disease. Role of
Right.
radiotherapy is purely palliative if it is causing symptoms. Otherwise, for disease control, I don't see any role of radiation.
Dr. Upasana, do you want to add something?
Sain, can I add one
Yes, please.
comment? Yeah, so we did a small study as a part of our thesis, and we did after 4 to 6 cycles of chemotherapy, if there was a good response, we did add, and most of the time SBRT to these cases, you know, if they were just paraortic nodes or with the SIB long course RT, and we did see a decent disease-free survival, and RT did manage to improve a very impressive progression-free survival. So I don't think we should give up, because if they've responded to chemotherapy, they are, I think, a good biology, and though they have a record, but still, and it also matters what time they have record from, you know, from the primary treatment. So if they record after, say, after 1.5 years, then definitely radiation can come in later, much later after chemotherapy. So we should not give up. Yeah, thank you.
Thank you. It's a very valuable opinion. So what about trastuzumab? Do you think it's a metastatic disease now, so trastuzumab might help?
So yes, if it is HER2 positive.
Okay. So do we have Dr. Saikat Gupta with us? I think he has not joined. So we have covered almost all the aspects of this case, and the consensus is perioperative chemotherapy to start with FLOT regimen. And when it is a metastatic, then we'll do the markers and we'll decide on immunotherapy or palliative chemotherapy. So that was the case. Thank you all. So we'll move on to our next session now. Thank you to the panelists. And if anyone wants to add any comment, they can add, because we have 2 minutes time left.
Sayan, can I say something?
Yeah, sure, please.
So as discussed even previously, I'm still not very much convinced for whether we should definitely prefer perioperative chemotherapy or cross. Definitely, we will have a lot more better answers with the results of Top Gear and Critics 2 and ESOPEC. By that time, even if you are preferring cross in these kind of patients, I don't think so. It's wrong for the patient, and I would still somehow I feel that even cross can be tried because because see, most of the previous trials they have mixed group of patients. Unless we have trials which has compared only EG junction patients, the trials either they have included esophagus and EG junction or EG junction and stomach. So, and there is just a small population of EG junction in both group of patients. So it is very difficult to comment actually, looking at their data. But yes, these trials will give, like ESOPEC and all these, they will give a better, we will have a better understanding about this disease in these trials.
Thank you, Dr. Samir. Dr. Upasana, do you want to add something on Dr. Samir's view? Do we have Dr. Upasana with us?
Dr.
Yeah,
Upasana, please unmute yourself.
Unmute. Yeah.
I think she is not able to unmute.
So if there is any technical issues, last word from Bhavna ma'am on this case.
So I think I would be more in favor of, like I said, perioperative regimen, because that has shown a 15% overall survival benefit. And I think the other thing I would urge everyone to do is in metastatic setting in gastric cancer, we have changed practice on overall survival data. So I think that is what we should go for rather than the current immunotherapy trials having PFS as an endpoint.
Thank you all. So thank you all for joining to this case discussion. We'll be having few talks on these topics also, and then there will be a summary, and we'll show our survey results, the practice pattern in India. So thank you all the panelists, and thank you chairpersons. So now over to Dr. Divya.
Dr. Upasana, if you could speak now, if the technical committee can look into it. She has raised her hand. Okay, we move on to the next session. Thank you very much, Dr. Sayan and our esteemed panelists. And I request Dr. Kishore Singh sir to please invite our next speaker.
After a very good panel discussion, now it is time for discussion on pattern of failure after D2 gastrectomy and target volume. The speaker is Dr. Sayan Das, followed by discussion by discussant Dr. Ritika Hinduja, Dr. Umesh Velu, Dr. Leena Gupta. Dr. Sayan, please.
Hi, am I audible?
Yes, Dr. Sayan.
Yeah, thank you. Thank you. I would like to thank the organizers first, and a very good evening to all of you. Are my slides visible now?
Not yet.
I've started sharing my screen here. Are my slides visible now?
Yes, yes, they are.
Yeah. So again, a word of thanks for the organizers for arranging this excellent conference regarding the management of gastrointestinal tumors. So I'll be deliberating briefly on the patterns of failure after a D2 gastrectomy and what implications it has on the radiotherapy target volumes. So I think I would better skip these parts because this has already been discussed that it is the third most common cancers among males in India. Surgical resection, as has already been mentioned, remains the mainstay of curative treatment for localized gastric cancers. However, even after radical resections, the locoregional recurrence rates are comparatively higher, which refers or which brings in or necessitates the use of further therapies in the form of chemotherapy mostly and radiotherapy in certain cases. There are various treatment approaches, and there's a continental divide with regards to approach to management of locally advanced gastric cancers. If you look at the United States, based on the results of this INT0116 trial, the regimen that is often called the McDonald's regimen, which says upfront surgery followed by adjuvant chemoradiation is what is practiced, whereas in or was practiced in the European countries, based on the results of the MAGIC trial, the perioperative chemotherapy was more popular. And now, as has been already discussed in the previous session, that the MAGIC regimen is now gradually being replaced by the FLOT protocol, which has shown survival benefit compared to the MAGIC protocol. Whereas in the Far East, based on the results of these randomized phase 3 trials like the Classic and the ACTS-GC studies, adjuvant chemotherapy is the norm. So if you look at the treatment roadmaps, so post-op chemoradiation, peri-op chemotherapy, or post-op chemotherapy alone, these are kind of the standard treatments in the various parts. People have looked into post-op chemotherapy versus chemoradiotherapy, as has been seen in the ARTIST followed by the ARTIST-2 trials, which kind of says that the role of post-op chemoradiotherapy is now somewhat limited. People have looked at peri-op chemotherapy versus adding radiotherapy in the post-op setting in the critics trial, which again shows that the benefit of radiotherapy is minimal. And as has been seen, that since delivering post-op therapy is difficult, as a large chunk of patients are unable to receive their treatment, so the attention is now towards delivering most of the these radiotherapy or chemotherapies in the pre-op setting, and the Top Gear study is looking into it. I think the next speaker will be discussing in details about that. Now, when you come to surgery, what is accepted is a D2 lymphadenectomy. So you do a total resection of the stomach, so either a total or a subtotal gastrectomy, along with a lymph node dissection that would include a D2 lymphadenectomy. Now, as has been shown previously, in the Asian countries, the lymph node yield is much, much higher than what is often seen in the Western countries. Even in the Western countries, D2 lymphadenectomy is nowadays recommended, but provided it is performed in a high volume center by experienced surgeons, which has acceptable rates of post-op mortality. Now, based on the results of the Dutch D1, D2 trial, which compared a D1 versus a D2 dissection, long-term results did indeed show that D2 does lead to better outcomes. Now, before we understand what D2 entails, we just need to have a quick go through the lymph node stations. These are, although it looks very clumsy, it's somewhat pretty simple. The first 6 stations alludes to the perigastric lymph node stations. So the 1 and 2 are the right and the left paracardial, 3 and 4 are the along the curvatures, 5 and 6 are supra and infrapyloric. From 7 to 16, these are mostly around important vessels. Say for 7 is along the left gastric, 8 is along the common hepatic, 9 is along the celiac artery, 10 and 11 are around the hilum and the splenic arteries, 12 is around the hepatoduodenal ligament, 13 is just behind the pancreatic head, 14 is along the superior mesenteric vessels, 15 is along the middle colic, and 16 is the para-aortic nodes, which have again been subdivided into 16A and B, and A and B are again subdivided into A1, A2, and B1, B2. These are important because the patterns of failure mostly occurs in these regions, and I'll come to it later on. So what should be the extent of surgery? The Japanese Gastric Cancer Association, which kinds of is a pioneer with regards to the management of gastric cancers, they in 1998 classified the lymph nodes into 3 groups based on the location of the primary gastric tumor. So gastric tumors were divided into 3 groups: the upper third, the middle third, and the lower third. And based on that location, there were 3 regions or 3 groups of nodes. Now that was pretty complicated because, say, a suprapyloric lymph nodes involvement would be group 1 for a distal gastric tumor, but for a proximal gastric tumor, a suprapyloric level 5 node would be at group 3 node. So because of its complexities, never really caught on. However, they said a D0 would be anything less than a D1 dissection. So D1 entails dissection of all group 1 nodes, D2 is group 1 and 2, and D3 would be removing all 3 groups of nodes. In 2010, they modified it and made it much more simpler. They said that lymph node stations from 1 to 12 and 14 V stands for the superior mesenteric vein. So what they said was these were categorized as regional gastric nodes, and anything else would be at M1. Now for a total gastrectomy, a D0 means anything less than a D1. A D1 would include dissection of levels 1 to 7. D1 plus means more than D1 but not yet a D2. So D1 includes 1 to 7 and 8A, 9 and 11. Whereas a D2 includes up till station 12. So this is just a small diagram which is taken from this paper that they published regarding the classifications. So it's 4 groups, mostly total gastrectomy, a distal gastrectomy, or a pylorus preserving gastrectomy, or a proximal gastrectomy, and they specified which all nodal stations have to be removed so that it is considered as a optimal resection or not. This is something that is of utmost importance when we are discussing about the patterns of failure and the role of radiotherapy in an adjuvant setting. Now, surgery is, depends on the expertise of the surgeon, on the technique that he's using. So there is a good amount of variability with regards to the quality of surgery. And for us radiation oncologists, it is at times very difficult to assess the quality of the surgery just by looking at the intra-op notes or the post-op histopathology reports. The staging nowadays refers to the number of nodes involved, and the D2 dissection, or the what sort of dissection is nowadays refers to the number of nodes dissected. So anything more than 15 is considered to be optimal. But the problem with that classification is it does not reflect the extent of dissection. And as I said, the long-term results of the Dutch trial showed that patients who underwent the so-called D2 dissection but were actually less than a D2, so either a D1 or a D1 plus, had local recurrence rates of up to 41%. So you need to sit down with your surgeon, sit down with the pathologist, and then assess what was the quality of the surgery. Coming to our topic for discussion, the patterns of failure, because this is what decides further adjuvant therapy. Now, there are several studies that have attempted to find out the patterns of recurrence, but the results are varied. And there are several reasons to explain why it is so variable. So it depends on the patient cohorts. So what was the stage of the patient that was chosen, the time points at which the recurrence were determined, what was the criteria for classifying the recurrences. So the para-aortic nodal recurrences, some group takes it as a metastatic disease M1, so distal failure, while some consider it as a locoregional failure. And also it depends on the extent of nodal dissection. Now, in common parlance, so 3 types of recurrences are usually considered for gastric cancers: distal recurrences, locoregional recurrences, and peritoneal recurrences. Among them, the common theme remains that distal failure is the most common, followed by locoregional and peritoneal recurrences. Several studies, which includes clinical as well as in a reoperation setting, as well as from autopsy series, we find that the locoregional rates are substantial with curative surgical resection. Out of these locoregional recurrences, it is the common sites remain the gastric bed, the site of anastomosis of the duodenal stump, the abdominal stab wounds, and the locoregional lymph nodes. Now, this paper looked at the patterns of regional recurrences following a D2 dissection for stage 3 gastric cancers. And what it shows is the frequency of the lymph nodes at initial surgery and then at first recurrence. Now, the black rectangles, or the black boxes, they refer to the frequency of the positive lymph nodes at initial surgery, whereas the gray ones reflect at first nodal recurrence. Now, what is obvious is, if you look at them clearly, so the nodal regions which were dissected and showed positive rarely recur when the patient has a locoregional recurrence. As I said, in a D2, you cover till station 12, whereas majority of the recurrences are occurring in station 16, followed by 12, 13, and 14. So these recurrences occur beyond your field of D2 dissection, which, if you're planning to offer adjuvant radiotherapy, must be covered. This is just a diagrammatic representation of what I actually said just now. If you look at the red dotted area, which is the theoretical field of a D2 surgery, whereas your theoretical radiation field that was used to practice beforehand still does not cover the areas which are having locoregional recurrences, especially the 16Bs. So what should be our target volume for radiotherapy in a post-op setting following a D2 dissection? Well, developing a uniform standard for contouring for a post-op RT target volume is difficult. It is because of the different sites and stages and lymphatic mets that is seen in gastric cancers, and the various surgical methods that are applied, and the conditions of the post-op cutting edge. Still, what is commonly practiced is people tend to include the residual or the remnant stomach, the anastomotic site, the gastric bed, and the regional lymphatics. The dose remains around 45 grays in 25 fractions over 5 weeks, and it has been seen that the use of high precision techniques like intracellular modulated radiotherapy leads to less toxicity. Because if I just mention one point, is in the INT0116 study, they had used conventional APPA portals, and almost 17% patients failed to complete radiotherapy because of significant toxicities. Now, there are several contouring guidelines available. So starting from the gastric surgical adjuvant gastric reports to the Kundras and Tepper's guidelines, the critics guidelines, the EORTC ROG expert opinions, and the gastric lymph node contouring atlas was published in 2013. Now, what are the key informations that we must have while we sit down and start our contours is the location of the primary tumor, because the nodal involvements depends on the location of the primary tumor. So you need to look at the pre-op images, the risk of lymph node spread according to the primary location, the type of surgery that was done, as well as the type of anastomosis, the resection status, so whether an R+ surgery or not, what was the extent of the lymphadenectomy, and the final histopathology report. Now, if you look at the randomized controlled trials that used post-op chemoradiotherapy, so I've just jotted down 4 of them: the McDonald's regimen, the RT study, the NCC done in South Korea, and the IMRT study in China. If you look at the target volumes, most of the studies have included lymph nodes 1 to 16. However, the RT study included nodes 7 to 9 and 12 to 16. Also, the tumor bed was mostly included. However, if you look at the completed rates, when you use IMRT, the complete rates are 91%. Whereas when you use conventional techniques, the completed rate is around 60% only. So now let us come at one of each of them one by one. What about remnant stomach? Remnant stomach was included in the previous studies, but not in the ARTIST trial. There are several, the ARTIST trial decided on their contouring volumes based on their own study of the patterns of failure, and they found out that the remnant recurrence in the remnant stomach was very low. Even this study, Chang et al., they looked at almost 2,000 patients who underwent a subtotal gastrectomy, and only 15 of them had a local relapse in the remnant stomach. So, and also there are a few retrospective studies that have shown that whether you include the remnant stomach in your target volume does not lead to any significant difference with regards to survival rates. So if the surgery is optimal for a subtotal gastrectomy with adequate margins, you probably may avoid treating the remnant stomach, whereas there is another school of thought which says for T3, T4 tumors, it is better to include the residual stomach. Tumor bed is usually included for T4 tumors where there was evidence of adjacent organ invasion. Otherwise, if you do a complete R0, it may be avoided. How do you identify? It's based on the surgical clips. In most studies that have analyzed the patterns of failure, among the sites having local failures, the most common remains the anastomotic site. However, duodenal stump may be or preferably covered in patients who have a partial gastrectomy for distal tumors. For proximal tumors, probably you may avoid a duodenal stump provided the margins are all adequate. What about nodal volumes? Well, as I showed, most of the phase 3 trials had included nodes 1 till 16 number of stations. The ARTIST trial avoided treating the perigastric nodes. So what they said was, if the patients are receiving a standard D2 dissection performed by well-trained, this is a very important word. So with a sufficient nodal yield following the surgery, you may avoid treating the perigastric nodes. However, the ground reality in the part of the world where I belong is much more different. So it is better to include the perigastric nodes. And the point that I keep on repeating is the most common recurrent nodes are outside the field of dissection. So these must be included in your target volume. Especially nodes 16, the para-aortic nodes are the most common recurrent sites, irrespective of the site of the primary tumor. Now, if we go by site-wise, so in the proximal third of stomach, the most commonly involved nodes are the stations 9, 10, and 13. In middle third, it is 12 and 14. In the distal third, it's around 9 to 14. And when a large part of the stomach is involved, the nodes commonly involved are, again, station 2, 9, 11, 12, and 14. And in some areas, like the splenic hilum, in the perigastric area, and below the IMA, so the recurrence rates were very, very low. So this is what I usually follow. So for proximal or for cardiac tumors, you must include the cardial, paracardial nodes, nodes along the curvature, the gastric, the celiac, the splenic nodes, the hepatoduodenal, station 13, the behind the pancreas, and the para-aortic nodes. For middle part of the stomach, you can avoid treating the paracardial and the middle colic. Whereas for distal tumors, you can avoid the splenic nodes as well. So the salient points that I would like to harp on is for gastric patients who undergo a radical D2 resection, local region recurrences are substantial. Most of them occur outside your dissection field. A rational design of your target volume is crucial for optimizing local regional control. As I said, quality of surgery is very, very important. And you need to sit down with your surgeon, with the pathologist, discuss in a multidisciplinary team before you decide on offering post-op radiotherapy, which I feel must be individualized. Thank you all.
Thank you very much, Dr. Sayan, for a wonderful lecture. And now I request our discussants to please give their valuable comments, and if they have any questions or if they want to add up something.
Dr. Ritika, you have to unmute yourself.
Okay. Am I audible now?
Yeah.
Yeah. Hi, I'm Dr. Ritika. I would just ask you one question.
Dr. Ritika, can I interrupt? Can you be slightly louder? I can't hear you.
Can you hear me now?
Actually, earlier you were audible. No. Yeah, now you are unmute. You are mute.
Some issue with your mic. It is unmute, but you are not audible.
So till then we can go on to the next discussion.
Yeah, so Dr. Umesh can ask questions.
Hi, Dr. Sayan. I think you can hear me. It was wonderful talk. I just wanted to ask you regarding the implications of critics in our day-to-day practice as radiation oncologist. How comfortable are you in this scenario of omitting RT, especially based on a critics trial? Because if you see the study design of critics trial, it's a non-inferiority trial, but it's the investigators have used intention to treat analysis for their methodologies. And in that case, only 40% of the patient never even received the planned treatment. So it defeats the purpose of intention to treat anyways. So based on this, how comfortable are you to omit RT in stomach? And my other part of the question is, if you want to add RT in a post-op setting, is there any special scenarios like N2 or N3 where you would prefer using RT?
Well, thank you for your question. Well, these are very pertinent questions. So what I say is that before deciding on adjuvant radiotherapy, so again, D2 dissection is probably not the only thing that you look at. You have to look at other clinical pathological factors as well. So which includes the histological conditions, the size, the site, the depth of invasion, what was the macroscopic type of the tumor. Looking at all of this, see, from now, based on the results of the critics and the artist too, nowadays I offer post-op radiotherapy to for gastric cancer in a very limited setting. So my indications are pretty limited. So unless there's an R1 resection or there is so only nodal involvement, so a PN2 or a PN3 is not a strong indication to offer adjuvant radiotherapy based on the result. Although I do agree your point, a large fraction did not complete treatment. When you look at artist 2, again, the results are the number of events that were expected and the number of events that actually occurred are much less. So yes, I think the opinion is still out, and it has to be individualized. You look at the patient, how fit he is, and look at the risk of recurrence that he has, and then you decide.
Am I audible now?
Yes, you are.
Yes.
Sorry, I just logged out and logged in. Am I interrupting somebody?
Not at all. No, absolutely, you can go ahead.
So that was a very nice talk. I'm sorry for the technical problem. So I had one question. When you as we know that with the patterns of failure, the most common recurrences occur in the station 16. So would you include, and we, as you also mentioned, that it's divided into A1, A2, and B1, B2. Would you include A1 and B2 in all cases, or would you, because that's going to B2?
Yeah, that's an excellent question. So if you look at some of the studies that have included the studies that have looked into the patterns of failure and that have a large number of patients with a pretty long follow-up, what they have found is that isolated recurrences in 16 B2s are very rare. So that is why, unless there is involvement of 16A1, I rarely include 16B2.
I think you mean involvement of A2B1.
Yeah, sorry. Unless there is involvement of 16A2, I rarely include 16B2 because isolated failures in below the IMAs is much less. I mean, very, very low.
And thank you for the answer. Just one comment. So there is also one very good, it's a Chinese study from actually Wuhan, from where COVID came, but they have talked of some new guidelines recently published in 2018, and they gave a very good description of the entire thing for the participants to read. That's it. Thank you.
Hello.
Yes, ma'am.
I'm Dr. I'm Dr. Leena. Dr. Sen, thanks for the talk. I am calling from Arunachal Pradesh. I'm practicing there. And I think I just want to highlight that in my state, Papumpare has the highest incidence of carcinoma stomach. But ours is an Oriental race. They have more Mongoloid people here. And I think the treatment pattern that we give here, like following, generally we follow FLOT and 3 cycle of ECF according to the patients, followed by D2 surgery. And then we give 3 or 4 further adjuvant chemotherapies. But we have seen a lot of recurrences. Radiation in our state, we are just having cobalt right now. So, but my personal experience has been like, even with 2-field radiation, the toxicity has never been so much. So, and the presentation in our place is generally late, and it is mostly in the distal part of stomach, pylorantrum. So do you think for us in a remote place, should we take up a more aggressive management with radiation also? Because I have seen a lot of recurrences in my population.
So, madam, by recurrences, you mean recurrences in the
nodal and peritoneal as well. So what we do, because of the risk, high risk, we generally after this chemotherapy, perioperative chemotherapy, we generally take up patients just to avoid the risks on capecitabine, maintenance capecitabine also. That we, some patients actually, that might not be a correct protocol, but because the compliance and the people are not very compliant and they really live in very remote places. So we take them on capecitabine. Do you think it is on the correct line, or should we, because of our population and greater stage, take up for radiation also?
Well, madam, to answer your question, well, it is probably a very relevant question in your part of the part that you practice. Well, adding maintenance cape, I don't think there is any strong data to back it up in gastric cancers. With regards to your recurrences, well, what people have added post-op radiotherapy, and if you look at the results of these meta-analysis, what it shows is that if you add radiotherapy, probably you have better loco-regional control, and in some results you have even probably a statistically significantly better disease-free survival. But whether it does indeed lead to better overall survival is probably no.
Even that we doubt. Even that we doubt. Thank you so much.
If there are no more questions and comments, so I request Dr. G.B. Giri sir to please invite the next speaker.
Thank you, Divya. It's my pleasure, and especially, I would like to thank the speakers. Some brilliant lectures. Dr. Das, your lecture was really very good, very practical. It's my pleasure to invite Dr. Rebecca Wong. Dr. Rebecca Wong is from the UFT, from the Department of Radiation Oncology, practicing at the Princess Margaret Hospital. She is a clinician investigator with more than 100 odd papers, peer-reviewed papers with almost 8 or 10 book chapters. She's also the director of clinical trials program in radiation medicine at the Princess Margaret Hospital. And her area of interest has been in GI malignancies. So it's my pleasure to invite Dr. Wong to give her a talk on the role of pathological CR, especially after neoadjuvant radiation, which of course really translates into overall survival. Professor Wong.
Thank you, Dr. Guri. I'm trying to share my screen. Just give me a sec. You're not seeing my slides, are you?
We are.
We can. Oh, you are. Okay, great. Thank you. Okay, thank you very much for having me. I want to take the opportunity to thank the organizing committee, particularly Dr. Misra, a good friend who gave me the opportunity to join you today. Here are my disclosures. And I also want to take the opportunity to acknowledge my key collaborators on Top Gear, Dr. Trevor Leong, leading the study as a PI from Australia, and Dr. Hausterman from EORTC, my colleagues at Princess Margaret and the Princess Margaret Hospital Foundation. You've seen these slides in other talks already. Globally, stomach cancer is the 5th most common cancer in the world. It's actually moved up from a few years ago, but the 3rd leading cause of death. The point I want to make is that gastric cancer is heterogeneous in many different ways. From a prevalence point of view, there is an over 10-fold difference between North America and the high incidence countries such as Korea, with India somewhere in the middle. It's also heterogeneous from a pattern of spread, response to treatment, and outcomes related to location, nodal station at risk, routes of spread, histopathological subtype, and genomic characteristics. As our knowledge base grows, our critical eye on the type of admissible evidence that we draw upon to guide decision-making for gastric cancer should be based predominantly on gastric cancer, and study populations that are related to G-junction, distal esophagus, or broad terms like gastroesophageal or esophagogastric should be scrutinized carefully as to whether it actually informs the question that we're trying to answer. So to answer the question that the planning committee have given me, will neoadjuvant radiotherapy by increasing pathological complete response rate ultimately translate into improved survival? I thought it will be helpful to separate into various components. Why are we interested in pathological complete response rate? How often does pathological complete response rate occur in preoperative therapy in gastric cancer? Is PCR related, prognostic, or causative to long-term survival? And what is the effect of preoperative radiotherapy? We'll take a look at some of the ongoing trials that is poised to give us a definitive answer and a few thoughts for the future. First, why is there so much written about PCR? Well, it does have lots of appeal. It is gratifying for the patient, for the physician alike, that the tumor is shrinking. It suggests and tells us that the tumor is highly sensitive to the treatment that we're delivering. It's available drugs to move forward in the clinical setting. However, our biostatisticians, our trialists will tirelessly remind us, and I'll do that also today, that PCR is only an intermediate outcome. Whether PCR is a prognostic factor and is associated with long-term survival benefit, or is it just a prognostic factor, needs to be proven. There are lots of papers with mixed overall conclusions. Another reason there's so much written about PCR is the ability for it to enable paradigm changing in approaches. The classic scenario is in anal cancer, where there's a very high pathological complete response rate. And this is coupled with no loss of overall survival by deferring surgery, significant benefit of organ preservation, which outweighs the increased difficulty in doing surgery in the salvage setting, coupled by strong diagnostic tools to give us a confidence that we can safely monitor for complete response, making organ preservation standard of care in this disease. The journey in other disease sites such as rectal cancer, esophagus, squamous cell is much slower and ongoing since the path-CR rate is much lower, and the accompanying factors that need to be established through robust trials are only gradually emerging. The other application for PCR is to use it as a prognostic factor, just to tell the patient that you're going to do well and is expecting a favorable outcome. Or you use the prognostic factor to tailor postoperative therapy. And in selected circumstances, it can be used in phase 2 trials to expedite our discoveries. The methodology to establish whether PCR is a good surrogate measure for overall survival is well described. Ideally, based on meta-analyses of multiple randomized trials through regression analysis to demonstrate a high coefficient of determination, R-squared. So how often does it happen that we get a PCR with preoperative therapy in gastric cancer? And is it prognostic for survival? There are actually no shortage of single-arm, single-institution studies, and a few that are selected here with nice headlines that suggest that we get a significant likelihood of pathological complete response rate, be it with chemotherapy or chemoradiation. In looking at these overall, the range that has been described is anywhere between 5 to 40%. However, in larger randomized trials, the PCR rate is much more elusive. Here are a couple classical studies, the Magic Trial on the left and the FLOT4 trial on the right. While there's significant downstaging effect was described, there's no actual PCR that is described in these trials. A systematic review of over 1,000 patients from 7 trials, 5 of them retrospective, 2 prospective, reporting on PCR published in 2018 would suggest that with preoperative chemotherapy, the PCR rate is about 6.7%. Another approach is taken by looking at population-based databases, and the large US National Cancer Database have been used in for multiple papers. And this is one of the largest one, including most of the patients, looking at both chemotherapy and chemoradiation preoperatively. Here, the pathological complete response rate reported is only 2.2%. Applying the methodology of the meta-analysis approach was published by Petrelli in 2018, and using 22 trials, they were unable to find a correlation between PCR and overall survival. And you can see the graph displayed on the right. The R-square is 0.17. So based on the evidence that is available to date, PCR is unlikely to be a good intermediate outcome for testing preoperative chemoradiotherapy. I do want to remind ourselves that most of the studies that are included in these work, such as this one, meta-analysis, they include predominantly distal esophagus, G-junction, proximal cardia type of tumors. And out of these 22 trials, only 3 of them included gastric cancer patients that are non-cardiac, and all of them were testing preoperative chemotherapy. So how about radiation? What is the effect of preoperative radiotherapy? The interest in preoperative radiotherapy parallels the work that is done in esophageal cancer, although much slower given the smaller number of patients, and perhaps more challenging in delivering this treatment. There are 4 small randomized trials that use preoperative radiotherapy alone, including a total of over 1,000, just under 1,000 patients. The studies are small, relatively poor quality, but within those limitations, there's a suggestion that there's a survival benefit. A series of studies led by Dr. Jani methodically go through the various stages of development and tested preoperative chemoradiotherapy in a sequential fashion. And they're summarized here, again, showing very promising overall survival benefit and favorable toxicity profile. If one looks in the literature that talks about this topic, what is the role of preoperative radiotherapy from gastric cancer, you can't stay away from the esophagus-based literature. And here's just a very high-level summary of that body of literature looking at esophagus and G-junction tumors. And within the network meta-analysis that we conducted, you can see that there is potentially overall survival benefit and although higher postoperative mortality, comparing pre-op chemoradiotherapy versus pre-op chemoradiation. So there's lots of interesting data. There's randomized trials suggesting that they may, for small trials that suggest that there may be a benefit. It's the ongoing trials that we're looking forward to that will give us the definitive answer. There's a pair of trials from China that opened in the last few years and is poised to complete accrual by 2023, asking these questions, both of them including over 650 patients. The one in the southern part of China looking at CELOX with radiation added, 45 gray, and the one in Shanghai region looking at S1 and combination chemotherapy with radiation added preoperatively. Of course, the Critics 2 trial has been mentioned several times already, is a 3-arm and non-comparative pick the winner design, comparing pre-op chemoradiotherapy, adding cross chemoradiation after some chemotherapy, as well as the cross approach alone. Top Gear trial, I was fortunate enough to be able to be involved together with Dr. Liang, and it's now almost poised to complete accrual. The trial opened to accrual in 2009 and is calling for a sample size of 570 patients, and is expected to complete any day now. Being a collaboration between Australia, Canada, and ERTC. The primary endpoint is overall survival, and the secondary endpoints as listed here. The first interim analysis that was completed and published after the first 120 patients is summarized here. What it shows us is that the compliance of receiving the treatment preoperatively is high, with 93 to 98% completing pre-op chemoradiation and 92% completing the chemoradiation. Post-op chemotherapy is challenging, as we know from the Magic Trial, in the order of about 50%. In terms of toxicity, serious toxicity associated with perioperative therapy and associated with surgical morbidity is similar between the two arms, suggesting that it's going to be a well-tolerated regimen. Out of interest, the first phase of the study actually is powered based on a go-no-go of pathological complete response rate, looking for an improvement from 5% to 22%. If the current trial provides favorable evidence that preoperative chemoradiotherapy improves survival, it is envisaged that there will be significant scope to improve the therapeutic ratio with this strategy, just by improving the quality of radiotherapy. For example, strategies controlling breathing, gastric motion, which really is at a relatively rudimentary level in designing these gastric trials, can potentially reduce toxicity. Testing the treatment volume as to whether dose painting to give a little bit more dose to the lymph node region and perhaps sparing the luminal structures may improve local control and maybe long-term outcome, as well as reducing toxicities. And the application of novel tools such as MR-Linacs to accommodate motion to reduce margins are strategies that we anticipate will be able to improve the therapeutic ratio going forward. In a Top Gear trial, an atlas was provided as part of the protocol, as well as a quality assurance program. the pass rate of the first submission is about 72%. And the most common reason that is the need for resubmission is contouring undercoverage around the area of the duodenum. Again, and there really isn't a lot of change over time. So the need for quality assurance and quality of the radiotherapy will be important going forward. I'll take a moment to speculate. Since we don't have the answer and we'll have to wait. I anticipate that preoperative chemoradiotherapy will be associated with improvement in outcome in the longer term with the preoperative strategy. If that's indeed the case, I think future international RCTs on preoperative therapy dedicated to gastric cancers with a lot of international collaboration, I think will move us forward. There are other strategies that can further enhance outcome of gastric cancer, better gastric imaging to detect PCR and take us down the route of anal cancer. Theranostics is a growing field that we're also involved in, and perhaps targeting HER2 will be a good strategy to complement chemotherapy and radiotherapy. Designing more effective and iso-effective and less toxic preoperative therapies, I think is the way to go, and targeted therapies, of course, and high-risk patients in the postoperative setting. So my take-home message for us today is that PCR is expected to show a modest increase with the addition of preoperative chemoradiation, but a lot of work needs to be done in order to determine whether there's a role for it as a strong intermediate outcome or indeed in guiding therapy. Preoperative chemoradiation, when combined with the state-of-art chemotherapy, which no doubt will continue to improve, is expected to be tolerable and effective in improving overall survival. And gastric cancer trials, gastric cancer specific trials with international collaboration will enable us to open a lot of doors and get incremental answers. Thank you for your attention.
Dr. Giri, please unmute.
My apologies. Sorry. Thank you, Dr. Wong. Professor Wong, I mean, it is certainly tantalizing for us to look at pathological CR and whether it works as a surrogate for the overall survival, as is probably seen more in the upper digestive tract tumors, especially in the oral cavity and the head and neck. I would like to open the talk for discussion. I'd like to invite Dr. Singhal, Dr. Devnani, and Dr. Bhattacharya to formulate and to ask the questions.
Good evening, sir and ma'ams. It's always very difficult to ask questions after such a nicely illustrated discussion. I have only one question, ma'am. What radiological criteria would you consider for having a better path CR? Like what kind of radiologically, because we don't have a detailed histopathology report. So what kind of radiological criteria would you look into to have a better pathological CR in the future, anticipated pathological CR?
Yeah, that's also going to be speculation. In fact, as it is now, we would have situations where the path report will say there's no response. And then we go back to the cross-sectional imaging and we can see the tumor shrinking. So I think even the interpretation of what is a pathological response estimation could benefit from more work taking into account what we're seeing preoperatively. But having said that, to answer your question, I do believe that PET scans, cross-sectional imaging, gastric specific protocols, I think is important. It's not always done. And I think in expert centers, the radiologists will know that we're looking at a gastric cancer and use the appropriate protocols. But unless that is used, it attenuates our ability to detect. PET scans is not routinely available in Canada for gastric cancers. But I think that, that there is a potential role to play. And similarly for endoscopic ultrasound, I think it's very operator dependent. And in our environment, we have lots of experts using it in esophageal cancer, but less so in stomach. So I think a combination of those tools would be valuable. And finally, I would like to mention about the theranostics model. The ability to image HER2 receptors is, there's lots of promising data there. I suspect that would also enhance our ability to exclude active cancer going forward.
Thank you, ma'am.
First of all, I want to thank Dr. Wong for a wonderful lecture, and it's really intriguing. And I would like to ask one question to you, ma'am, that is there any role of radiomics and proteomics to predict the response in future? Like, what's your opinion that about the role of radiomics and proteomics in this case?
Yeah. I think probably say like your center's radiomics mixed radiation oncologist is very excited. So I think the answer has to be yes. I think we are really using genomic information, even those that it's known to us at a relatively rudimentary level. So having more understanding as to how those will guide our choice of therapy will be important. I think having large international collaborations so that we build large databases will really help us understand the radiomics going forward.
Okay. And I have another thing to ask you, ma'am, because you are talking about we are trying to reduce the preoperative toxicity of radiation also, because that is one of the key concerns. So do you think, is there any role of particle therapy in this regard? Though we are not very sure about the photon yet, but I am asking, what's your opinion about particle therapy in this regard?
Yeah. I have to admit that we do not have particle therapy, so my answer will be based on my general understanding. I think that tools such as MRL and good use of cone beam CT to look at the changes in the stomach from day to day, I think will be a much more accessible strategy for most of us. I think particle therapy, I think will be really good to target the nodes. I'm not as certain it will be have as much therapeutic ratio in targeting the stomach or the tumor bed area, since in the post-op setting you can't see it, and the pre-op setting it moves around. So maybe a good tool for boosting, but I think Dr. Misra and I have talked about the organ motion, and we put like a centimeter around our stomach. Do we really know that that is enough? And I think having good data to monitor, we don't want to put 3 centimeter margin. Yeah, we won't miss the tumor, but we'll treat a lot of unnecessary tissues. But ways of limiting the margins and know that we're not missing a tumor, I think will be important going forward. Hope that answers your question.
Okay, madam. Thank you.
Thank you for informative talk, ma'am. I would like to know that in the era of advanced chemotherapy, what is the incremental benefit we gain with the radiotherapy by adding it in a preoperative setting? And one more question I want to ask is there any dose response relationship? Like in POET trial, the radiotherapy dose was 30 grain, cross it was 41.4. So do we have any dose response relationship?
interesting questions. I think, again, speculation, I think adding radiotherapy, you can think of as adding an extra drug. So it's, to me, it's a cross-resistance issue. So you may have different types of resistance, and by adding a modality that is not chemotherapy, I anticipate that it would complement the chemotherapy. Therefore, I believe that it should have a role to play in the management of the disease. The trick is to reduce the toxicity, to keep it isotoxic. You could add a 7-drug chemotherapy and maybe do the same thing, but I guess you'll be increasing the hematological toxicities, whereas with radiotherapy, the toxicity profile is very different, and if we can keep it acceptable, then they're complementary. So I think that's my guiding principle. And of course, the tumor bed area is where we are targeting. So we have the advantage of using geometry to target cancer cells as opposed to systemic therapy where it's systemic. I do think that the future will be less volume. The volume that we're treating is based on the McDonald and the surgical literature. With improving chemotherapy, I suspect we can target the areas that is of most concern and not to use such a giant field, but lots of research need to be done to get there. Dose response, I think that if you have an oligometastases, there probably is a dose response in eradicating a gross site of cancer. In the preoperative setting, the design of the radiotherapy dose is to preclude causing significant surgical toxicity. So that 45 dose mark tend to be quite universal across preoperative treatments, and it also happens to be the dose tolerance of stomach. So I think if we are talking about the whole volumes that we're treating, I don't think we can go much higher. However, I think targeting the nodal areas, we could probably go higher with the right techniques to spare luminal structures. So that's a very non-answer to your question, but I think it depends where we're talking, which area of the tumor we're talking about.
Thank you. If there are no further questions, Dr. Bhattacharya, please. Yeah.
Sir, can I ask a question?
Kinjal?
Yeah. So in fact, we have Dr. Rajneesh Singh. He's a surgical oncologist from Chandigarh, and he has an experience of operating the patient of CS stomach after a preoperative radiotherapy. So can we have some comments from him about his experience on that? Dr. Rajneesh, if you're there and you can answer this question.
Yeah, hi. I'm actually part of the SGPGI team in Lucknow. Nevertheless, so this is working with Dr. Shaleen, Dr. Shagun Mishra, and Dr. Shalini Singh. Our team was inspired by the Top Gear protocol way back. Prior to that, we were working with the Magic protocol. And so, although our volumes have been very low as compared to the accrual by the Top Gear team, but I can give you a flavor of what the surgeon kind of feels about preoperative CTRT, apart from what you have read in the Top Gear protocol. So the first thing is that surgeons are devastated by thinking about operating on irradiated stomachs. I think Dr. Wong would identify with that. And it's been an uphill battle to try to convince the rest of my surgical team to actually operate in these patients. So from whatever nascent data we have, I personally had to operate all of them. That's the first thing. Second thing is and I'm talking about my own experience, very small experience with our own team. If one is very careful with the radiation fields that you've described, Dr. Wong, and which our own team works with, and we work very closely with each other, the surgical mobility is no more than what we were following earlier, and our earlier protocol was the Magic protocol. the three areas which are often of concern to the surgeon in gastrectomy. One is the duodenal stump. The second is the esophageal margin in a total gastrectomy, that is. And the third is the gastric bed. The duodenal margin and the esophageal margins do show radiation changes. This is, I'm talking about actual experience. They require careful handling. There's absolutely no question about that. The tissues are different from what you experience in perioperative MAGIC protocol. But given careful handling, the morbidity in our hands has been no more than what we have experienced with the MAGIC protocol. The one experience which I'd like to share and I'd like to have Dr. Wong's comment on this, is that akin to what the cross protocol and surgeons from the esophagus data have shown us, that pre-op CTRT reduces the lymph node yield in the chest. It's been a very nascent kind of observation from our own team that it seems that you get a lot of sclerosis in those lymph node stations. So the bunches of lymph nodes you normally get in a D2 gastrectomy, you simply don't find. So the number of lymph nodes we get in a properly done D2 gastrectomy is still lower than what we used to get when we followed the MAGIC protocol. So that is an observation which I don't know will be hold out and bear out in time or not. But the bottom line is that the morbidity in our experience has been no more in the pre-op CTRT protocol as opposed to what we followed earlier, and that is the MAGIC protocol. And we've had no incidences of radiation injuries to organs, which otherwise would cause us to have sleepless nights. Thanks.
Thank you so much for the inputs, because this is something which we wanted to listen, and I'm sorry for the Chandigarh and the Lucknow thing. But yeah, this is something which we wanted to know, that what I hear from my surgical team is also the same, that the complications what we fear, that with the preoperative radiotherapy there will be a lot of complications, but in practical terms we have not observed that. Any comments from Dr. Wong, if she has to make a comment on that from her?
Yeah, I have to say I haven't been to the OR, so but looking at the data, it does not show there is increased toxicity. I think your experience is exactly what we have here as well. I ran around the country trying to get people to participate in Top Gear. There are people that are very adamant that there will be increased toxicities and they are worried and they would not consider the trial, and that continues for the duration of the study. I suspect there would be some increased toxicity. We are radiating the area, but I think given how difficult it is to give stuff post-operatively, I think if we can work together, I think the data would support that there is no significant increase in late toxicities. And in terms of the number of lymph nodes, I agree with you that the number of lymph nodes seem to be lower. Having said that, in our surgical specimen, definitely it's more than 15, which is kind of the bar that we want to go with. So we did not have any trouble having that sort of minimum number of lymph nodes in our specimens.
Thank you. One thing for sure, Rajneesh, you're going to be a very popular surgeon among the radiation oncologists.
Very unpopular amongst my own colleagues.
Yeah, that's fine. But the thing is that, again, what Professor Wong was also saying is that when we go ahead, we have this concept that we are just giving you about pre-op doses of 45 gray, and it really should not cause too many complications. And especially if you do it probably 3 weeks down the line, you should still be able to find your planes. There's going to be a certain amount of edema or bleed. You should be able to find your planes for you to be able to dissect. Understandable that if you take it a lot longer, if you take it somewhere 7 weeks or 8 weeks down the line, then you might end up having this problem of wound dehiscence, and your bite will just, you will end up having a problem with that. So I don't know at what stage that you were taking it up post CTRT, how many weeks you kept it in between, but it's certainly nice to hear that your experience is not exactly shared by most of the surgeons, or the myth that it's really causing too many complications. So thank you, sir, for clarifying that.
Thank you.
If there are no further questions, can you?
There is one question in the chat box by Dr. Somnath Mukherjee. So do you consider asplenia prophylaxis for patients after gastric radiation? It means splenic dose exceed 10 gray. It means clinic dose exceeds strain gray. I think it's to Dr. Wong.
Well, we do not treat the whole spleen, so we treat the splenic hyla. I actually have not measured the dose to the spleen and have not seen hematological or clinical issues that I would relate to radiation dose exposure to the spleen.
Can I sneak in a question?
Sure.
Hi, Dr. Bong. I'm just asking, I mean, given the low compliance rates with the adjuvant part of the chemotherapy, have researchers considered getting rid of it altogether?
Yes, I guess it would be a non-answer because I think it probably can be dropped in some patients. So I think it's a bit of a dose phenomenon. We have had patients who have, I think if you have a complete response up front or complete and minimal residual response, I personally think that those will be the group of patients that really don't need the chemotherapy afterwards, but that's we need a trial to prove that. But for patients who have some partial response, I think the chemotherapy would make sense. I think the concept of total neoadjuvant therapy was raised and is in the literature. If we can get it in preoperatively, I think that will be a good strategy, although it's a fine balance between not compromising the patient too much for surgery. So I think for some group of patients, it's good to officially drop it, but it requires more data.
Thank you.
I'm afraid we will have to call.
Do you think that histology is going to play a big role in this regard? Like if you see that ARTIST trial, we have seen that intestinal type of pathology has shown better results in a subset of patients. If you go for cross trial, there you will find that there was a lot more PCR in the squamous cell carcinomas. So what is your prediction? It's all speculation and prediction. How you feel that, whether in this regard also histology is going to play a big role?
Yeah, I agree. I think it was probably like squamous and adeno for esophagus 10 years ago. Like I used to treat everybody the same, but now we clearly distinguish between them. And I think that as we have more of these large trials to give us robust data, we will recognize that intestinal is different from diffuse and we should handle them differently.
Thank you.
We will have to close the session because we are running late, considerably late, I would say. So may I request Dr. Kishore Singh to come back onto the stage, please.
After 3 wonderful talks, it is time to summarize the session. And who else is better than Dr. Shaleen to do this job? Over to you, Shaleen.
Thank you. Am I audible, sir?
Yeah, carry on.
Okay, I'll start my screen share. Let me see, how does that happen? Oh. Excuse me. Start screen share. I'll share my screen and can you see my slides?
Yes, sir, visible.
Thank you. Right. So, so the summary of the session has been I would obviously talk about Dr. Sayan Das's presentation and Professor Rebecca Wong, and there's an additional brief that has been asked of me to see this in the Indian context, and therefore we'll share some information and some thoughts on this. Right. So, excuse me, I just want to get rid of some, hide the panel. What's wrong with this? Excuse me. Okay, so coming to the patterns of failure and volume implications, which Dr. Sandas talked about. I mean, he spoke about the challenges in ascertaining the extent of nodal dissection based on the histopathological report and the various problems that were there. He did emphasize that distal failure is the most common, followed by peritoneal and local regional failures with some similar values. An important point I thought he brought up was that nodal regions that are dissected rarely recur. And that was an interesting point. So you might have disease in nodal regions and that are positive, but having addressed them, that's not a problem. And but the nodal stations that usually recur 9 to 16, but more commonly 12, 13, 14, 15, 16. These are the paraiotics that are also covered in line with, you know, according to the upper and lower borders that we have on 3D CRT, IMRT contouring that we do. And then for contouring, he has reiterated what we generally do and follow and know that you have to have all your information, preoperative, operative, and anastomosis, status of nodal sections, follow the guidelines, and he's mentioned all of those. And anybody who is in this business would sort of make it, make the necessary effort to understand and do these things. And of course, include the gastric bed only if there's evidence of adjacent organ infiltration. Okay, so now coming to Prof. Wong's presentation, I thought there was a point that has been made throughout the day, and a lot has been said about the pathological CR, whether it's comparing MAGIC with FLOT, and whether it's looking at antigenic therapies, immunotherapies. We're quite a lot concerned. We think that, well, if the path CR is good or better, then it's necessarily a better treatment. But I would like to expand a little bit on what Prof. Wong has actually alluded to, and in fact, draw on her reference point, because I thought this is really important. Now, correlation of path CR with better survival does not imply causation. This is important. Correlation does not imply surrogacy. That means it's a good surrogate for survival. If you're looking at causation, that means the path CR is actually responsible for better survival, or that the path CR is a good surrogate for survival, the relationship must be proven. So the effect of a treatment, now this is how it is done. The effect of a treatment on a surrogate endpoint, that is, in this case, CR, it should fully capture any effect on the final endpoint. What's the final endpoint we're looking at? DFS or OS. So both have to go hand in hand. So the methodology that she described is that when you have a meta-analysis of multiple trials, effects of treatment on presumptive surrogate endpoint, the presumptive surrogate endpoint being PAT-CR, is compared with the effect of treatment on the final endpoint, which is OS, say for instance, through regression. Now the coefficient of determination R square, which she talks about, provides a quantitative estimate of how changes in the presumptive surrogate endpoint estimate changes in the final endpoint. That means what exactly is the relationship between PAT-CR and the survival outcome, the OS? So if you have an R square of 0, it's no association, an R square of 1 is perfect association, and an R square of 0.75 is considered acceptable. So this is now let's look at the data that she talks about. Okay, and we'll come to that in a while. Now there is a lot of variability in the PAT-CRs with preoperative chemotherapy. If you look at single arm studies, they are very encouraging, 5 to 40%. If you look at the randomized trials, the PAT-CRs are 0. So when you increase the rigor of assessment, it becomes, it's closer to where it is generally, when you look at systematic reviews of 1,000 patients that she talked about, it's 6.7. When you go down to the population, which is where actually you want to translate these findings, it's just 2.2%. That's the effect of preoperative chemotherapy. Now, excuse me, a small problem. Okay, I'm going to work on this. I can't see. Yeah. So if you look at the relationship between PathCR and OS, in this database of 14,000 odd patients, PathCR of 2.2%, chemoradiotherapy was not better than CT. You had 22 trials she talked about where there were 4,700 odd patients that received CT or CRT. The treatment effect on surrogates did not corroborate with OS. Now the R square is 0.27 when you compare PathCR with DFS, which means it is not the reason for the DFS, and it's 0.17 for DFS and for OS. So it is the effect on OS. So the regression, the coefficient of determination is not reaching a level that we would consider to be showing a cause and effect relationship. Let's look at preoperative therapy, clearly, and post-op chemoradiotherapy. In trial settings, again, when you have preoperative therapy, clearly there is an increase in overall survival by 5 years from 20% to 30%. The odds ratios are significant. And when you look at post-op CRT, it is also significant. Now, when you look at the population-based data, in the SEER data for 10,000 patients, there was no survival benefit for patients who received pre-op or post-op compared to the no RT group. However, when you look at lymph node positive patients, then both pre-op and post-op radiotherapy have some significance. And this is, of course, in the data. So there's always discordance between trials and what happens on the ground. Okay. If you compare what is the differential effect of when you compare radiotherapy, chemotherapy, or chemoradiotherapy followed by surgery, and this is about 31 randomized trials, network meta-analysis. So neoadjuvant chemoradiotherapy did improve overall survival when compared to all other treatments. When, say, for instance, the hazard ratio with surgery alone, compared to surgery, it's 0.75, it's significant. Compared to chemotherapy, it's again significant. Compared to neoadjuvant radiotherapy, it's again significant. But neoadjuvant chemorads also increases morbidity and mortality. Okay, so now let's look at the spectrum in India. Now, this is what we want to talk about. And I've referred to a paper from Chennai, a team from Chennai there. This is the reference. They talk about the ground realities. We heard a participant today talk about what's happening in Arunachal Pradesh, where or in Assam and the challenges, and that you don't have cobalt equipments, etc., and so on. You don't have accelerators, and there are challenges. So the resource level in India varies from basic, enhanced, or maximal. Clearly, the private sector, the freestanding facilities have everything, and that's what we often see. Now, centers with basic level facilities have endoscopy and ultrasound. Surgeries are D0 or D1. When they have CT scans, they may do D2 as well. With enhanced facility centers that have endoscopy for diagnosis, you may have HER testing, and they undergo D2 gastrectomy and therapy, and then you can go on to trastuzumab also. So there's a complete variability. Now, the majority of surgeons treating gastric cancer believe in doing a standard dissection of D2, although few of them still think D1 is enough. And this is from a survey of 1,500 surgeons conducted sometime in 2015, 2016 by this group from Chennai. Let's look at some national guidelines. Now, this is from the National Cancer Grid, and the reference is here, and it's in 2020. I don't think it's changed currently. Interestingly, there's a lot of talk about pre-op chemotherapy, preoperative treatments being given, and that's important. I wonder, in how many cases here, we actually do a laparoscopy in the locally advanced gastric cancers, T3, T4s, N+. The data is that if you don't do a diagnostic laparoscopy before subjecting them to chemotherapy or any strategies which are designed to definitive strategies, you can have, when you do a laparoscopy, you have up to 20 to 30% peritoneal dissemination, and they get excluded, they go into the palliative arm. If you don't do that, which is what is optional here, the reason for being optional is that it is costly. It is not possible to always offer a pre-diagnostic laparoscopy. Patients pay out of pocket, these facilities are not available, and they're not always done. And then the rest of the algorithm starts. So I'll share with you some information, some data about how we have been working. We've been looking at perioperative chemotherapy, MAGIC protocol, and we recently, for the last 2-3 years, we also looked at simulating the top care protocol. And this is interesting. Now, we looked at these patients, and it's important to state here that they did not have laparoscopy up front, a diagnostic laparoscopy. They had CT scans, and as far as could be judged, high-resolution CT scans, thorax, abdomen, pelvis, as far as could be judged, they did not have dissemination. So we start them with chemotherapy, which is ECX. The first cycle is 100%, the second cycle is 93%. By the time you finish 3 cycles, by the time you finish 2 cycles and you start pre-op chemo rads, you find it's already down to 64%. You see progression. This progression is coming from those patients who actually already had disease. And by the time you finish pre-op CT, it's down to 54%. And when you do a laparoscopic evaluation at that point in time, you might still find the odd patient who still has dissemination. You do surgery in 46%, and then you start adjuvant chemotherapy in 39%. And by the time you come to the last cycle, it's a good 25%. Exactly the same thing is seen if you give perioperative chemotherapy, the MAGIC protocol. When you patients, you start them with 3 cycles, where by the time you come for a preoperative laparoscopy, which is done just prior to surgery, you're down to 55% of the starting numbers because those who are destined to progress actually do, notwithstanding the chemotherapy. And then perioperatively, you see further dissemination, and palliative surgeries are done in a proportion. And finally, the numbers who complete all 3 cycles are about 30-35%. In this context, it's a bit intriguing that a lot of colleagues have talked about FLOT, etc. And clearly, FLOT was considered, although the paper talks about equivalent toxicity, but it is more myelosuppressive. And we find it difficult to do this on the ground. And so, so finally, to sum up, you see, as the question was asked, do you need to go? Are we going to see stopping the post-surgical therapies because patients are debilitated, they don't want the treatments, so it's better to sort of intensify the preoperative phase. And in fact, that's what the design is that Prof. Wong alluded to. And so these are the ground realities really of working in India. Thank you very much. I'm happy to take questions if that's permitted.
Thank you, Dr. Shali, for summarizing it so beautifully. Now I hand over it to the organizer. And Dr. Shagun.
I think probably Dr. Kishore, sir.
Okay. Thank you very much, sir. I request Dr. Jivigiri, sir, to please invite Dr. Shagun Mishra for the survey results.
Thank you. I will not be giving any this one. I think we are well over time. So may I request Dr. Mishra we had a small survey before we came here. So it would be interesting to see what the survey showed. Shagun.
Am I audible?
Yes, you are.
This at the outset, and I'll just go straight to my talk because of lack of time. We have heard from various experts that some form of adjuvant treatment in gastric cancer is required. The reason being that with surgery alone, the outcomes are really dismal. When we look at the international era, there are multiple options that are available. The North American strategy of post-operative chemorads. In Europe and UK, you have perioperative chemotherapy and adjuvant chemotherapy primarily being followed in the Eastern countries. And most of these interventions have produced about 10%, 8 to 10% improvement in survival in different continents. The interesting part is that the results are not replicated when studies are performed in other continents. And the reasons could be due to the differences in presentation, biology, and the difference in the surgical standards. So let's talk about the Indian scenario. And we designed this conference to come onto a consensus as to whether to follow the East or the West. And as alluded in the talks, we have a disease presentation, which is very similar to the West. You have higher T stage and end stage. But the disease biology is very similar to the East. We have more of distal tumors and intestinal variety. What is very unique to Indian scenario are the poor patients a very interesting topic that was introduced by Dr. Reena was on sarcopenia and poor nutrition. So whenever you're deciding on a strategy, the best way to go forward is to explore the feasibility and effectiveness of regimens in your setting. So when we sat down to design this conference, the first thing that came to our mind as to what is the practice variability in our country, and to assess these variability by way of certain questions and case scenarios. So for that reason, we designed a survey. And the survey was circulated to all of you. All of you have very kindly completed the survey. We had about 374 responses. That's quite a good response. So the broad outline of the survey was, there were some general questions as to where do you practice, what's the surgical expertise, do you have an MDT discussion? And there were certain case vignettes. These vignettes were discussed by the tumor board, and of course the experts. They summarized these vignettes very well, and these vignettes were based on certain challenging case scenarios. So let's look at the survey. And when the first thing we looked at was the region-wise registrations, and we have fairly good representation from Northern and South India. One thing that I could see was the representation from the eastern part of the country was not so. Is important because stomach cancers is one of the most common cancers seen in the northeastern part of the country. One more thing that I want to mention about the epidemiology of stomach cancers, it's one of the most common cancers in 11 states in the country. And it is the cancer which is responsible for the poorest DALY, that is the disability adjusted life years. Amongst all the cancers, stomach cancer is responsible for the worst DALY, followed by lung and breast. So that's why it's important to treat this cancer well. So the first question that we put across to you was, what is the nature of organization that you're primarily affiliated with? And interestingly, overwhelming majority came from the public or the charitable trust. About 13% of the participants were from private sector. And what about any formal teaching courses running it at your organization? About 2/3 did have a formal teaching in their center, and about 1/4 did not have a DNB or MD running at the center. The third question was, do you practice radiotherapy in carcinoma esophagus and stomach? And an overwhelming majority, that is 2/3 of them again, said yes for both. And about 1 in 5 said yes only for esophageal cancers. We also looked into the radiotherapy equipments, and this was something which came as a surprise to me. As we saw earlier, that majority of these centers were from the public sector hospital, and you can see now there is a change. About 2/3 of them do have a linear accelerator available with them. There were about only 5% of the respondents who had only telecobalt as an equipment. The other question we asked was, do you have a dedicated GI surgeon in your institute? And again, we got a very good response that about 2/3 would have a dedicated GI surgeon. Number of gastric cancer that you see every month, and the majority would see about 1 to 5 cases, which is, I think, is a pretty good number. As you must have heard through the lectures, that a multidisciplinary discussion is very important, not only for stomach cancers, but I believe for all cancers. And we wanted to understand that whether they have an MDT meeting for patients with GI malignancy specifically, and about 80% would say that they would have a kind of MDT. We also wanted to understand as to what do they call as a multidisciplinary discussion, and we asked questions as to whether you discuss all your cases before starting treatment. And here you can see only 50% of the patients are routed through the MDT before starting any treatment. About 1/3 would be discussed on as needed basis, and a minor proportion would not undergo any kind of MDT. So coming to the case vignettes now. So this was the case which was presented by Cyan. Basically a 69-year-old gentleman able to swallow liquids, disease in the lower esophagus, proximal stomach, adenocarcinoma. There is a growth which is seen on the endoscopy, 35 to 44 centimeters. Whole body PET scan shows disease which is pretty localized. He's a good performance status with no comorbidities. And we asked for the various options for treatment, and these were the various options which were given to the respondents, and each option had to be ranked in order of priority. So for example, if you have option 1, that is surgery followed by adjuvant treatment, if you think it to be the best option, you are going to rank it as 1. So there was a ranking priority. Rank 1 is the highest priority, and rank 4 is the lowest priority that you give to that particular option. So coming to the first option, that is surgery followed by adjuvant treatment, and very few patients would actually rank it as priority 1. And when we look at combined 1 and 2, which is relevant, about 40% would consider this as an option. I just looked into the data, fiddled the data to see as to whether there is a MDT, when do they have a MDT for stomach cancers. And what you can see from this data is that only 18% of them would have a MDT before treatment. The remaining would have it on as and required basis or post-surgery, and about 6% would actually not have MDT at all. The second option was neoadjuvant chemotherapy followed by surgery, and here you see that about 1/3 of the respondents would consider this to be, would rank this as priority 1, and 70% of them would rank it as priority 1 or 2. And when you look at whether these people have an MDT, and the patients routed through the MDT, certainly certainly have increased in this respondent population, and about a third of these patients would have MDT before treatment. The third option was neoadjuvant CRT followed by surgery, and this appeared to be the winner, mainly because probably this was a radiation oncology gathering, and when we look at option 1 and 2, it comes to 77%, and as you can see that when you are starting to integrate radiotherapy, the majority of patients would be routed through the MDT before treatment. So these are the kind of differences that we could see. And I also looked into whether the people who are offering neoadjuvant CRT, is there a difference in the equipment? And what we could see is that all of them were actually equipped with a linear accelerator. None of them were actually cobalt-only setups. This was the fourth option, and that is radical RT followed by weekly cisplatin, and this option was ranked very, very low by most of the respondents. So coming back to the case Vignet, and these were the options, and basically neoadjuvant CRT followed by surgery was ranked 1, neoadjuvant chemotherapy followed by surgery was ranked 2, surgery followed by adjuvant treatment ranked 3, radical RT of course ranked 4. So neoadjuvant CRT seems to be the consensus, at least amongst the respondents, but from the panelists and the experts, I think both these options seem to be in competition with each other. The second question was presented by Kanu, a distal stomach who underwent a distal gastrectomy with a D2 dissection. And it was a PT4A N1 disease. The patient was planned for KIPOX as per their NDT discussion. And we specifically asked, do you want to advise radiotherapy in this patient? She's undergone upfront surgery. And the options we asked was, would you give the patient no radiotherapy? And if you decide to give radiotherapy, whether you would give it post-operatively after 6 cycles of chemotherapy, or whether you would give it as a sandwich regimen. And again, the ranking priority was rank 1 is highest and 3 lowest. And when we talk about no radiotherapy, it was about 50% of the patient of the respondents would rank it as 3. That means half of them would be wanting to give radiotherapy in the post-operative setting. Only a third would rank it as priority 1. I looked into the responses, again fiddling with data, as to whether people who are not offering radiotherapy is because of the kind of setup, and there was no correlation. Only 6% of patients had cobalt, the remaining had a linear accelerator at the setup. The second question was in this Vignet, if you offer post-operative radiotherapy, when will you offer it? After 6 cycles of chemotherapy or a sandwich? And here, again, I mean, I don't think so there seems to be a consensus, but it is ranked low in terms of priority. Only 1/4 would rank it as number 1. But when you look at the third option, that is, do you want to give a sandwich regimen? That is just like the artist. About a third would rank it as number 1. So actually no consensus, but what we made from the panelists and the experts is that for in a post-operative setting, particularly in a T4 disease or margin positive, who has not received perioperative chemotherapy, people would consider offering radiotherapy in the setting. And so the same consensus was derived from the participants, that 50% would offer radiotherapy. And regarding the regimen, whether they want to give it after 6 cycles of chemotherapy or as a sandwich, most of them would give radiation as a sandwich regimen. I thank you very much. I would like to thank all the participants for taking time to fill in this survey. And all of us should always remember medicine is a science of uncertainty and an art of probability. And hopefully these lectures and guidance from the experts will help us estimate the probabilities better and reduce the variability in practice. Thank you very much.